Sorry, Tim, I will confirm just now. We're supposed to be going live in just a little bit. It's just taking longer than expected.
Okay, my side it says we're live now. So I think we can proceed. Thanks, Tanvir, and thanks, everyone. Welcome again to this event for our live viewers who've just joined us here. This is a combined event by Amnesty International, Oxfam, and ICJ. I'm Tim Hodgson, and I'm the legal advisor for the International Commission of Jurists on the Africa team. Today's event is aimed at trying to start working more together towards increasing equitable vaccine access, COVID-19 vaccine access in Southern Africa, which incorporates, as you'll see, more countries than what most people think it does. And we've got participants from all of the different regions in all the different countries in the region. We'll begin with the first hour where we've got two keynote speakers, very highly esteemed keynote speakers that you'll see. But before that, we would like to ask the Regional Director of Oxfam, Nelly Ngangwa, to introduce the event and to talk a little bit about Oxfam's work on vaccine access. So Nelly, if you'd put your camera on and you would come to the floor.
Thank you. Can I just check that you can hear me? And I'm on camera as well. Hopefully you can see me.
We've got you fine. We've got you fine.
Okay, brilliant. Thank you. So yeah, let me start by welcoming everybody to the space. I think I can see 49 people already in. We really appreciate that you are able to join us this morning. It's a very important space for us. And I am very thrilled definitely to join this discussion on equitable access to COVID-19 vaccines in Southern Africa. It is such a timely and important discussion to have, considering that delayed access to affordable, safe and effective COVID-19 vaccines for all and free of charge will continue to stand in the way of our government's economic recovery plans and programs. And so we are all aware how devastating COVID-19 has been to economies. And we believe that our hope comes with the vaccine, and any delay in that effectively delays our growth as a region. I would like to thank Amnesty International, the International Commission of Jurists and Oxfam staff, and all of us gathered here today for kickstarting this great conversation in our region. Comrades, ladies and gentlemen, you will agree with me that in the SADC region, the pandemic is not the horror that it has been played out to be, but rather a true reflection of the underlying gaps in our economic and social structures that have trapped millions of people in poverty and inequality for decades. The COVID-19 pandemic has effectively just exposed it. It's been there and we have lived with that. And the pandemic has fed on it and deepened the existing structural inequalities that we have seen for a long time. There have been countless unnecessary deaths because for decades, our governments did not invest in public health care and the social protection systems, which could save lives during these difficult times. As we discuss COVID-19 vaccines and the recovery from the pandemic, it is important that we talk about re-engineering our deeply unfair economic models so that they work for all and not just for a handful of people. This is a greater vision for Oxfam in Southern Africa. We believe that the region is endowed with a lot of resources that if governments committed to a fair distribution of the resources as well as the growth, we should be getting a lot of people out of poverty. It's our belief and it's our vision for the future that a just and fair Southern Africa is possible. Today, the shame of COVID-19 pandemic is the fact that the vaccine, which is our only hope out of the pandemic, is further segregating the haves and the have-nots. And we can see that in many places. While developed countries are already vaccinating 1 person for every second, Africa continues to be pushed further behind the vaccine queue. Developed nations are not only holding the vaccines, but pharmaceutical companies are charging African governments higher prices for the little doses they are able to access. We saw South Africa paying more than double the price that the European Union had negotiated for the same vaccines. It is morally wrong, and we want to emphasize that it is morally wrong that governments have to incur in this part of the world, governments have to incur more debt or cut down on social spending in order to access the overpriced vaccines. Even before we even ask for lower prices, we are just looking at fairness. Why should Africa be overpriced? The World Health Organization led the COVAX facility, which was supposed to provide doses for 20% of our people, has not lived up to the expectations yet. Last week, we did ask one of our researchers to look up how much vaccines have been received through COVAX facility in the SADC region, and found out that no country has received enough vaccines to even vaccinate 1% of its population. That's how unfair the game is. Allow me to just give you a few examples of what we have found out. Angola, for example, has received 624,000 doses, and that's just enough for 0.95% of the entire population. Malawi has just received 360,000 doses, enough just for 0.94% of the population. Lesotho has received 36,000 doses, enough for just 0.84% of its population. DRC, which has a population of 85 million people, has received 1,700,000 doses, again, just enough for 0.95% of its population. And lastly, Mozambique, with just 384,000 doses received, will only be able to inoculate 0.61% of its population. That's how the situation is, and we want to emphasize that it is not fair, it is not just. These figures are clearly telling us that the few charitable doses through COVAX facility, which we welcome so much, is by no means an acceptable solution required to end the crisis. There is more that's needed. More bold and urgent action needs to be taken. Action that will see big pharmaceutical companies share the science of the vaccines and the technology to enable timely mass production of enough safe and effective vaccines through COVID-19 technology access pool, which is managed by World Health Organization. We know that South Africa can produce the vaccines if the technology is shared. Rich nations must stop protecting big pharmaceutical monopolies. It is shameful that the US, the UK, and the European Union has continuously opposed South Africa and India's proposal at the World Trade Organization to temporarily suspend the trade-related intellectual property rights so that vaccine production could be scaled up. And it is a real shame. The proposal was supported by all the SADC countries because it could speed up the production and distribution of vaccines in the region. But unfortunately, that continues to be opposed. Suspending patents to end a pandemic that has shattered lives and brought the global economy to its knees is not too much of a ask. And I think it's commonly said that unless all of us are safe, nobody is safe as far as this pandemic is concerned. The lack of openness from our governments on COVID-19 vaccines, agreements and contracts, including the cost of procurement, financing mechanisms, and the distribution plans is also very worrying. As a few vaccine doses start to arrive in the region, we are seeing politicians, government bureaucrats, being the first to take up the few vaccine doses. Of course, it's in the name of building public confidence, but I think it's exaggerated a bit, and we worry that if this trend continues, we are going to get the people that deserve it miss actually the vaccine. And it's our ask that needs to stop. Lack of information on the source of efficacy of the vaccines being received in the region is also worrying, especially at a time when increasingly more countries like in Europe are raising concerns on their effectiveness and side effects, and they are suspending the use of some of the vaccines. It is in the interest of our countries and everyone, both rich and poor, that we urgently overcome access barriers to safe and effective COVID-19 vaccines and prioritize people most at risk. The more we delay access by prioritizing intellectual property rights and the profits for big pharmaceutical companies over people's lives, the more we will fail to prioritize people that are at risk, including frontline healthy and social care workers, essential workers, the older people, people with pre-existing conditions who are at higher risk, particularly those living with HIV/AIDS and the local humanitarian workers. The more we are also going to prolong the pandemic and increase the likelihood of new variants rendering the existing vaccines ineffective. Equitable access to safe and effective vaccines is the surest way of reopening our economies in the region. It's the surest way of reducing unemployment. It's the surest way to end the rising cases of sexual and gender-based violence that the region has experienced, and the rampant human rights abuses that have accompanied government-imposed measures to curb the spread of the virus, including lockdowns. Without equitable access, our frontline and essential workers will continue to be unsafe, and the countless unnecessary loss of lives and livelihoods will continue to be witnessed. If we fail to act now to end the pandemic, the question is, when are we going to do it? And lastly, I want to applaud this initiative and our coming together so that we can speak more loudly about these issues. And I want to believe that this is just the starting point. I think we need to commit ourselves to more action until we see what is desirable in this region come to pass. And so this space is a great space. And again, just to welcome everybody and to feel at home, and let's put our heads together and see what progress we can make for the improvement of our region. Thank you so much.
Thank you very much, Nelly, for that really good introduction. And Oxfam's really been at the forefront of highlighting inequality and the effects of inequality around the world before and after the COVID-19 pandemic. And now, just for another brief introduction from a human rights perspective, the ICJ Africa Director, Kajol Ramjathan Keo, is now going to speak for a few minutes, and then we'll move on to our keynotes shortly thereafter. Thank you.
Good morning to everybody who has joined us. The International Commission of Jurists, in cooperation with Amnesty International and Oxfam, have organized this symposium to initiate and facilitate regional cooperation between human rights defenders and public health experts in Southern Africa to advance equal access to COVID-19 vaccines. The symposium aims to provide a platform for national actors to jointly develop new strategies to advance state compliance with human rights and public health obligations in the process of vaccine acquisition and distribution in individual countries. We are hoping the interventions and discussions that we have during the course of this morning will assist us to move our advocacy forward as we work towards equitable vaccine access. We are grateful to have two keynote presentations this morning by virologist Professor Shabir Mahdi and human rights defender Fatima Hassan from the Health Justice Initiative. These presentations will assist us to frame our discussions in the Southern African region within the context of vaccine grabbing, vaccine hoarding, and vaccine apartheid by countries who refuse to waive the intellectual property rights for the local production and accessibility of these vaccines, which have been developed for the most part by public funds. The human rights implications of not procuring sufficient vaccines to achieve herd immunity in Africa is potentially catastrophic. This could result in a situation of serious restrictions on freedom of movement, both between African countries as well as between Africa and the rest of the world. This includes a situation where the unvaccinated become second-class citizens. These will invariably be already poor and marginalized populations. The impact of being unable to access vaccines will further exacerbate insecurity, poverty, and inequality. We hope that today's discussions will assist us to unite with the singular goal in mind, which is to ensure and achieve equitable vaccine procurement and distribution, both in Southern Africa as well as locally in our individual countries. Thank you for joining us. Back to you, Tim.
Thank you very much, Kajal, for that. I am going to take a liberty here and say that I'm going to skip some protocol because we're already running a few minutes late, as tends to happen on Zoom. So I'm going to introduce very briefly the first speaker and then the second speaker. And I hope that you forgive me because they have very long CVs. But first we have to speak to us an expert on virology, Professor Shabir Mahdi, who has done an extremely large amount of work in this area over a long period of time, but importantly has been one of the key voices giving the public information and providing advice to how governments should be able to pursue vaccine access strategies. And we are looking forward to hearing from you both on South Africa and Southern Africa and how you think we might move forward. So Professor Mahdi, thank you for giving us the time, and the floor is yours.
Thank you, Adam. Are you able to see my screen?
Yes, we can see your screen. We're looking at your desktop background right now.
My desktop background. You're able to see my presentation now?
Yes, we've got your presentation. Thanks so much.
Okay. So good morning, everyone, and thanks for this opportunity. What I'm going to do is really provide some thoughts in terms of what challenges we face when it comes to accessing COVID-19 vaccines. And I think also what's important currently for most of Southern Africa is the need to recalibrate our expectations of COVID-19 vaccines. Now, one of the major challenges that we face in Southern Africa and in fact on the African continent is that whilst there's a lot of talk about accessing COVID-19 vaccines, more than 12 months into the pandemic, what we still haven't been able to get right is to be able to access diagnostics to adequately quantify the burden of COVID-19 on the continent, both in terms of the number of individuals that have been infected, as well as the number of deaths that have occurred. So globally, what we've experienced currently is there have been roughly 120 million cases of COVID-19, of which 4 million have been diagnosed on the African continent. And as you know, Africa makes up about 18% of the global population. Of the 4 million that have been diagnosed on the African continent, close on to 40% of those have been diagnosed in a single country, which is South Africa. When looking at deaths from COVID-19, of the 2.6 million deaths that have been reported globally, we find 105,000 deaths being reported in Africa, of which about 50% are reported again from a single country. Now, unfortunately, what this lends itself to is an underappreciation in terms of the impact that COVID-19 is having on the health front. I think we're all aware in terms of the tremendous impact that it's had in terms of the social and economic conditions in different countries, as was pointed out earlier. But when it comes in terms of actually quantifying the impact that it's had on the health front, this is something that has been completely underestimated. And the reason for saying so is that when looking at the amount of testing that's being done per thousand of the population, what you find in Africa, across Africa, most of Southern Africa included, is a scarcity in terms of testing. So again, to reiterate, that we simply haven't even been able to get adequate testing into countries. And that really speaks to the fragility of our healthcare systems, as well as the systematic underinvestment in terms of healthcare on the continent. Even in a country such as South Africa, which does more testing than any of the other countries on the African continent, the rate of testing that's being done probably is roughly about 1/5 of the amount of testing that is being done in many of the European countries, as well as in North America. So what that lends itself to, even in a country such as South Africa, again, is a systematic underestimation in terms of the impact that COVID-19 has had, including on deaths. So in contrast to the roughly 50,000 individuals that have been reported to have died of COVID-19 based on confirmation of a confirmatory test, what we see when looking at excess mortality is estimate of close to 150,000 people now having died of COVID-19 in South Africa alone. So we're facing a situation which is analogous to what actually occurred in 2009. When we experienced the swine flu pandemic in 2009, again, what was experienced is that less than 5% of all of the diagnosed cases of swine flu were identified on the African continent and in Southeast Asia, which constitutes 38% of the world's population. Despite that, after the swine flu pandemic had passed and looking at vital registration statistics, what the CDC was able to estimate is that although only 5% of the swine flu cases were diagnosed on the African continent and in Southeast Asia, more than 50% of all of the deaths that occurred from swine flu actually occurred in these two regions. So we really face a major challenge in terms of not being able to adequately quantify the burden of disease because of issues related to availability and access to testing material. And again, to emphasize, this is an innate problem in our healthcare system, and it speaks to the issue in terms of underinvestment in health on the African continent. Now, what we experienced with swine flu as well is that with swine flu, because it was using technology which was similar to what is used for seasonal influenza in terms of vaccine development, the vaccine for swine flu was developed within a short space of about 3 to 4 months from the time of WHO declaring it to be a pandemic. But what there was experienced on the African continent is that there was almost no research done on swine flu once the vaccine became available. And in fact, the only time when the vaccine did become available to some countries on the African continent was when the pandemic had actually passed, including in South Africa. So largely unuseful, and this speaks to another major challenge. So much of the focus currently is about accessing large quantities of vaccine, but accessing large quantities of vaccine becomes somewhat meaningless if the timeliness of access is not dealt with. And for these COVID-19 vaccines to have an impact in terms of reducing death in Africa, in Southern Africa included, what we needing to be speaking about is not just about the quantity of vaccine, but we need to be needing to speak about the timelines of the access to those vaccines. So in a country such as South Africa, as an example, where it's indicated that we're likely to be able to procure at least 40 million doses of vaccine during the course of 2021, there simply is no timelines to that. And in all likelihood, by the end of the year, and certainly before any significant percentage of the population is vaccinated, we're likely to experience a third wave. And that third wave, there's no telling whether it will be more severe than the first or the second wave. So the timelines in terms of the access of these vaccines is of critical importance in this discussion. As was pointed out earlier, tremendous progress has been made in some countries in terms of getting large percentages of the population vaccinated over a relatively short period of time. In a country in South America, such as Chile, which is very similar in terms of its economic standing as is South Africa, what they've been able to achieve is vaccinating roughly 1.5 people for every 100 of the population. In South Africa, that figure currently sits at 1/100th of that, at 0.01 per 100 of the population. And in South Africa, as we know, it's not actually part of a vaccine rollout, but rather a vaccine that is being provided to healthcare workers as part of an implementation study. So there's a huge gap, and that gap is not only between high-income countries and low and middle-income countries, but even amongst middle-income countries, we're seeing this sort of gaps beginning to emerge, where some middle-income countries have been much more successful in terms of gaining access to vaccine at an earlier stage and being able to actually implement it into their immunization programs. Globally, what we see is that currently, as has been mentioned, a fair amount of some vaccine is being deployed through the COVAX facility to African countries. But the reality is that the amount of vaccine that's being deployed on the African continent in the past 2 or 3 weeks is less than what will be used in the United States over a course of 3 days. So currently, the United States, as an example, is vaccinating close to 2.4 million people each day. Which is more than the sum total of the number of vaccines that are available, as was indicated, to a country such as the DRC. So we do find some differences. Some countries have been highly successful, and those countries that have been highly successful in terms of vaccinating large percentages of their population, such as Israel, have been able to show that by getting people vaccinated as early as possible, you can really bring about an interruption in terms of the transmission of the virus. But whether herd immunity is something that will be realized on the African continent, and particularly in Southern Africa, I'll touch on that a bit in the next few slides. So the summary of it is analogous to what we see in terms of a map of the lack of testing that's been done on the African continent, or the paucity of testing that's done. When it comes to the amount of vaccine that's actually being deployed on the African continent, against huge gaps across the continent, except perhaps for Morocco, which has made some inroads in terms of being able to access 1 or 2 vaccines and have started to vaccinate a reasonable number of their population. So again, to emphasize, vaccine through the COVAX facility is beginning to roll out. Much of this vaccine, in fact, is a single vaccine, and that is the AstraZeneca vaccine. And the reason for that is that for the AstraZeneca vaccine, it's a vaccine for which there's the greatest number of manufacturers, and it's a vaccine for which we estimate that there would be at least close to 3 billion doses. 2.8 billion doses that will probably be available during the course of 2021, which exceeds the combined number of doses that might be produced by manufacturers such as Pfizer as well as Moderna. But the quantity of these vaccines that are becoming available is extremely limited. And again, to emphasize is that these vaccines are going to be of limited use if they only become available after the 3rd and the 4th wave of COVID-19 on the African continent. And in a country such as South Africa and perhaps many of the neighboring countries, we anticipate that the 3rd wave will arise as soon as May to June of this year, if not earlier, depending on what happens during the course of the Easter vacation period. Now, why do we find ourselves in such a difficult situation? So there's been much discussion about TRIPS and about the need for pharmaceutical companies to relinquish their intellectual rights when it comes to vaccine. But the reality that we need to face on the African continent is that even if the pharmaceutical relinquish their intellectual rights tomorrow, that does not lend itself to any guarantee that Africa would get access to any substantial quantity of vaccine in the foreseeable future. Even in a country such as South Africa, there is close to zero manufacturing capacity. When we talk of a company such as Aspen producing J&J vaccine, they're not producing vaccine from scratch. What they are doing is they're doing fill and finish. To be able to actually develop vaccine and do the full manufacture from scratch, right to the tail end of the production, would take at least 2 to 3 years to set up such facilities. In addition to which, we also need to be honest with ourselves that when we talk of relinquishing of intellectual rights, India is an example of a middle-income country which is as guilty as many other high-income countries in terms of placing restrictions on the export of vaccines, which are being produced by private companies within India itself. So what we face globally, and particularly on the African continent, is we largely, unfortunately, at the mercy of manufacturers, including manufacturers from middle-income countries, where we're simply unable to access those vaccines because of the governments of those countries imposing restrictions in terms of the export of those vaccines. Why are we where we are? This is an example of a failure. It's an example of a failure not just on the part of government. It's an example of a failure on the part of academia. It's an example of a failure on the part of the private sector. Investing in terms of manufacturing facilities when it comes to vaccines basically allows for a very low profit margin. And that is one of the major reasons why we simply haven't had any substantial investment in terms of vaccine manufacturing on the African continent, because that is not where money is being made, unless you large manufacturing companies such as the Serum Institute of India, which basically produce millions and billions doses of vaccines and are able to actually price it such that there's a very narrow margin of profit, but at the same time, they're able to generate their profits because of the large volumes. So to be able to compete against those sort of scenarios requires a very different sort of funding model that when it comes to investment for COVID-19 vaccines. Now, to end off with, an additional challenge that we face in Southern Africa is the B1351 variant that initially evolved in South Africa. And what has occurred is that this particular variant is somewhat resistant to the immunity that was induced by past infection due to the ancestry virus, as well as relatively resistant to most of the vaccines, the first generation COVID-19 vaccines, including the AstraZeneca vaccine. But that resistance probably differs depending on the severity of illness. We expect the clinical implications of that resistance to be more impactful against mild to moderate infection, whereas those vaccines might still protect against severe disease, including the AstraZeneca vaccine. And this was one of the studies that was concluded in South Africa, where we showed, unfortunately, that for the AstraZeneca vaccine, the vaccine did not protect against mild to moderate infection. But again, to emphasize that does not mean that the vaccine does not protect against severe disease. In fact, there's good biological reason and some studies in animals which strongly indicate that these vaccines, despite it not being sensitive to the antibody that's induced by these vaccines, by the AstraZeneca vaccine, will still protect against severe disease. Now, there's a number of vaccines that are becoming available. Some of these, unfortunately, are not going to be as easy to deploy across the continent. As an example, vaccines that need to be stored at -20 or even at -70 degrees Celsius. But what is common for all of these vaccines is that although there might be some variability when it comes to protecting against mild to moderate infection, for almost all of these vaccines, what we can expect is protection against severe disease, including severe disease due to the B1351 variant. For some of these vaccines, such as the Johnson & Johnson vaccine and the Novavax vaccines, we got much more direct evidence that these vaccines would have 80 to 100% protection against COVID-19 due to the B1351 variant. Whereas for the AstraZeneca vaccine, we probably at best have got indirect evidence that the same thing would materialize in terms of protection against severe disease. So where we are currently from a public health perspective is that for most of the Southern African countries, we're largely at the mercy of being able to access vaccines through the COVAX facility. And again, to emphasize, it's not just about quantities, it's about the timeliness of accessing those vaccines, because it might well be that after having gone through 4 waves of the pandemic, that we might be in a situation where the naturally induced immunity might be sufficient to protect, if not against mild infection, at least protect against severe disease. And certainly the data from South Africa strongly corroborates that, where in some regions that had a severe outbreak during the course of the first wave, those areas were relatively spared in terms of developing severe disease and COVID deaths during the course of the second wave. But this evolution of this B1351 variant, which has now been identified to be the dominant variant, including in Zimbabwe, from a publication that was released yesterday, as well as a separate publication from Zambia, the B1351 variant, not surprisingly, because of the huge amount of human traffic that takes place within Southern Africa, is probably the variant that is dominating in most of Southern Africa. So we need to really recalibrate our thinking of how we respond to the COVID-19 pandemic, but more importantly, or probably equally importantly, is to recalibrate our expectations of COVID-19 vaccines, especially this first generation of COVID-19 vaccines. The first generation COVID-19 vaccines is not going to get us to herd immunity. Unfortunately, that is no longer something that we should be speaking about on the continent. In fact, we need to become much more strategic in terms of who we target the vaccine to and for what purpose. And the main purpose of these vaccines in the context of Africa, Southern Africa, where there's limited quantity of vaccine and where we know that these vaccines are not going to be as protective against mild to moderate infection, is to really focus on vaccinating those individuals that are at high risk of developing severe disease and dying of COVID-19. And that is what the focus needs to be. So rather than trying to aspire to get 2/3 of the population vaccinated, which probably is not going to yield much value in terms of preventing mild to moderate infection, we should rather focus on how best and how quickly we can vaccinate at 20 to 25% of the population that are at high risk of developing severe disease and being hospitalized. Despite all of the challenges that we face on the continent, including with the evolution of the B1351 variant in South Africa, which has dispersed across Southern Africa now, despite those challenges, at the end of the day, fortunately, or unfortunately, depending what lens you want to look at it through, the COVID-19 vaccines remain the only sustainable option for reducing risk from severe disease and death. And again, to emphasize, we need to recalibrate how we think of COVID-19 vaccines, what we're trying to achieve with these vaccines, and the focus needs to be centered around preventing people from dying and reducing the pressure on our healthcare systems by vaccinating high-risk individuals. Thank you for your attention.
Thank you very much, Professor Madi, for giving us such a comprehensive run-through of the issues relating to the vaccine as updated to now. Can I ask participants, please? We have an anticipated question and answer session once both keynote speakers have spoken, but they have very limited time. If you can start by writing your questions in the chat here while the next keynote speaker is speaking, that will greatly improve our ability to get through the very busy schedule we have for today. So please start writing your questions. The second keynote speaker is someone who probably needs no introduction for people who've been following vaccine advocacy around the world. Fatima Hassan is the director and founder of the Health Justice Initiative, and she is a very experienced campaigner for access to medicines and human rights lawyer. I'll let her say the rest, and she will be talking from a human rights perspective about vaccines. So Fatima, thank you for joining us.
Thank you, and thank you to the organizers and to Professor Madi, the ICJ, Oxfam, and Amnesty International. So Tanvir is very kindly helping me with a few slides that I'm going to show you so that I can speak about vaccine inequity and access. Shall we show the slide on the maps, Tanvir? The next slide? Okay, great. So I always like showing both of these slides next to each other because the map on the left-hand side basically shows the dire access situation that Professor Madi has also spoken about, and the map on the right shows the opposition to the relaxation of intellectual property rules, including patents during the pandemic phase. So basically, this pandemic where we've now begun the phase of vaccine trade wars globally. Given the last 2 weeks developments, including even in Italy, in the EU, banning imports of vaccine supplies to Australia, and the diplomatic rows that we're now seeing between the EU and the UK and the US around limited vaccine supplies and the inability to honor a lot of these bilateral agreements, or what we call advanced market commitments. So the bleak access picture in the global south right now, and you can see that most parts of Africa are actually red, and the likelihood of population or regional immunity in particularly the global south is looking at 2023, 2024. So it's very evident to see, and it has very dire legal implications, moral implications, public health and human rights implications, and a severe strain on all of our public health systems. So if you look at the unlikelihood of immediate population immunity and what that means, it really shows you that because of the lack of access to vaccines, which is so far off, for many countries in Africa, we're going to be facing repeat waves and repeat lockdowns and a severe socioeconomic impact, as well as a strain on healthcare systems and particularly healthcare workers. So access to vaccines or diagnostic tests or any other technology that could actually become a meaningful intervention in this pandemic is obviously linked to supplies. Those who have supplies have started vaccinating their populations already, not their populations under occupation, not their populations who are refugee asylum seekers, but populations that they consider citizens. And those vaccination programs are already quite advanced in many parts of the world, which on the left map you'll see are indicated in dark green or in light green. And mostly they are wealthier nations who ordered more supplies than they needed in 2020 already, even before there was regulatory approval of some of the front-runner vaccines. Supplies are obviously linked to manufacturing and manufacturing capacity and ability and manufacturing permissions, which is linked to the ability to rely on multiple manufacturers in a pandemic to produce vaccines, which is unfortunately in this pandemic, like others, like the HIV/AIDS crisis, linked to monopolies and intellectual property protections, because your intellectual property rights give you an exclusive ability to exercise a monopoly. And that determines whether supplies can be increased fast enough or eventually. So what we need to change is that red part of Africa to green speedily is greater access through a relaxation of intellectual property protections, obviously ramped up manufacturing, as well as the transfer of vaccine knowledge and know-how. So it's not enough to give a sub-license just for fill and finish. You actually have to share the vaccine know-how and the knowledge and the tech transfer, so that Black and brown people around the world, particularly in Africa and the global South, can step forward and not be at the back of the queue. Failing which, what we're seeing already is that it's going to be survival of the wealthiest, survival of the richest, and in many cases, survival of the whitest. A system that is so morally bankrupt that no decent human rights defender or public health practitioner in Africa can support it any longer. Even the WHO, the AU, the Vatican, Dr. Tony Fauci have all recently warned against its implications and have asked for an urgent relaxation of intellectual property protections. So in essence, we need to treat the vaccine as a public good, not just say we're going to regard it as a public good, but actually treat it legally as a public good, which must be rooted in the right to access to life-saving healthcare. It can't be okay that healthy people are getting vaccinated in the US and in the UK and in other parts of the world. And those at highest risk, such as healthcare workers in Africa and other parts of the global South, are still waiting for access. We don't want a repeat of the HIV/AIDS crisis, but that's where we're at now. And so if you look at the map on the right, look at the countries that have more than enough supplies and are also now, like Canada and the UK, drawing from the limited supplies in COVAX. They are the ones that are mainly blocking the TRIPS waiver. It's a group of about 9 countries, and obviously the EU is a regional bloc. The TRIPS waiver request led by South Africa and India, which is now supported by over 100 countries. 57 countries are actually co-sponsoring it. So it's not a shot in the dark. The momentum is building, and we could actually campaign to win this waiver. But it's still being negotiated 1 year into this devastating pandemic, with the socioeconomic crisis that we're facing, with the public health crisis that we're facing, with the epidemiological crisis that we're facing. Countries are still negotiating this waiver in the middle of a pandemic when they promised us solidarity at the beginning. And not only is there opposition to the waiver, these countries are now refusing, the very ones who are vaccinating their own populations, are refusing to share current supplies of vaccines on an equitable basis, insisting that their pre-orders must be met first, and handpicking a handful of sub-licensees. There aren't enough sub-licenses for their own markets first, allowing secret monopoly deals to continue while treating intellectual property as sacrosanct instead of treating humans as sacrosanct. In addition, they're relying on export bans to limit vaccine supplies leaving their borders, and also vaccine source materials now over the last weekend. In the US, the Biden administration has acknowledged the impact of the COVID-19 pandemic and is using the US Defense Act to scale up manufacturing for domestic purpose, to relax intellectual property protections in the US, but not to do the same for the rest of the world and outside of the US. And particularly, the Biden administration is seized with the issue of ramping up and investing in the scale up of mRNA vaccine technologies, which is why as activists, we are so concerned about how the Biden administration will actually march in and ensure that the NIH Moderna vaccine is available for the whole world to use. So if we turn to the next slide, we can look at the issue of nationalistic over-ordering and what we call hedging your bets. And this is a snapshot of vaccine nationalism at play, which indicates that if we are to address the human rights violations in this pandemic, we also have to look at the countries and companies that enable this due to their monopoly power and sticking to their intellectual property claims in a pandemic for vaccines that were actually co-developed and co-funded by a number of governments and government scientists and public institutions, including conducting trials in South Africa. So the very same countries that have over-ordered, that have more than enough supplies than they need, and are also drawing from COVAX, are perpetuating now, through blocking the TRIPS waiver, a system of self-created scarcity in the world, leading to a lack of access in the global south. And it really doesn't have to be this way. Human Rights and Oxfam warned us about this in September and October of 2020 already. And what's really critical is that even though the over-ordering is in place in many of those countries, like I said earlier, vulnerable populations, sex workers, people who are refugees or asylum seekers, people who are under occupation in Israel are actually not getting vaccinated or not getting vaccinated fast enough. And so we need to focus on the big pharmaceutical companies and what we call big pharma. If we turn to the next slide, I'd like to spend some time on that one. So when we talk about vaccine nationalism and vaccine apartheid, let's just be very clear, this is deliberate. Vaccine manufacturers were heavily co-funded and supported in 2020 and also in 2021 with at least $10 billion that we know of. So it could actually be more because there hasn't been significant disclosure and transparency. And these funds were for accelerated research to get the world out of the COVID pandemic. They were supported by a lot of government scientists, a lot of knowledge that was actually developed before. And like the HIV/AIDS crisis, they are now, unfortunately, despite the co-funding and co-development, in the driving seat. They are determining supplies. They are determining access. They are determining, global and regional supply negotiations. They are determining price and intellectual property waiver requests. Their secrecy, their threats, their limited benevolence, their limited donations with a lot of PR and drip feed contributions to COVAX for 2021 are just hello, and are just unacceptable, including the low and no profit conditional pledges. They are not sustainable, they are not helping, they are not going to get us access. What we need is enforceable guarantees and a immediate relaxation of the IP system for the duration of the pandemic until we can achieve global immunity. And so really all of their actions and their PR offer no real solidarity for us. And our scrutiny of their business practices determined mainly by profit really needs to increase as human rights defenders on this continent. So the waiver requests and the countries blocking it I discussed earlier are tied into what we call big pharma, the front-runner vaccine companies that even the South African government and the AU are negotiating with, and that COVAX relies on. And we're supposed to be getting 700 million dosages from COVAX for Africa. But they are blocking the TRIPS waiver, insisting on deciding when and who gets access, not being transparent on a whole range of issues, including segmenting markets through their sub-licenses. What we know in South Africa is that there are now negotiations with all of these companies and now also Section 21 approval of the Pfizer vaccine. But when you look at their forecasts and you look at the projection of supplies that will actually be coming even into a country like South Africa, you're looking at late 2021 and early 2022. And then, of course, we have to deal with the fact that Pfizer has requested Latin America to put sovereign assets on its table to underwrite indemnity waiver and no-fault compensation schemes. So no one has seen the contract, no one has seen the pricing or the terms for indemnity protection. And our desperation for vaccines could potentially enable less scrutiny and even more human rights violations.
Sorry, can others mute while Fatima is continuing, please?
Thank you. So the handful of carefully constructed and non-transparent sub-manufacturing licenses that now exist because the EU, and that's the irony, the EU had a supply crisis a few weeks ago and the US is now facing one too, are simply not enough at the moment to vaccinate everyone everywhere, while regulatory approvals are still coming in. Not a single drug company has joined the WHO CTAP. They're not willing to share their technology or to transfer the vaccine know-how. COVAX is a pool procurement mechanism. It doesn't actually require compulsory tech transfer. It's actually just, a big negotiating block for a number of countries that need to rely on it to achieve equity. And it itself has said that there is a limited supply of vaccines, the supply is very slow, and that they're only able to cover about 27% of vulnerable populations in low and middle income countries by the end of 2021. Aside from the fact that COVAX is not very transparent on its pricing and its agreements too. So there's really no compulsory sharing. And once again, pharmaceutical companies are in the driving seats. It hides behind donations and small pledges to COVAX. In the case of Pfizer, it's only 2% of their supplies for 2021 that's actually going into COVAX. And so this really benefits, I think, the shareholders of these pharmaceutical companies, especially Johnson & Johnson, AstraZeneca and Pfizer, and of course, Moderna, because there's no compulsory regime for the sharing of technology, even though the rules of the WTO allow it in terms of the DAR declaration. So if we go to the last slide, I think Shabir has painted a picture of unnecessary death. We are in a situation where lives are on the line now in the global south, and really we need some urgency and a seriousness with which to address the lack of access, because it's having such a dire impact on all of us in the continent. And this is why we need vaccine equity, and for the broader scientific, public health, human rights, and legal community to join the People's Vaccine Alliance globally, to insist on transparency, not just of our own governments, not just of the South African government or the Zimbabwean government or the Congolese government, but of COVAX, of AVAT, the African Union Vaccine Acquisition Task Team, and all of the big multinational companies, including Gamaleya and Sinovac and Sinopharm, which incidentally have submitted regulatory dossiers to the South African regulator in the last few weeks. And we've got to insist on the immediate support for the TRIPS waiver and urgent manufacturing scale-up. So we really need you to use your voice and your power to ensure that millions of people don't necessarily die again. We've been through this through HIV and AIDS, and we really cannot do this again. So we really do need access. The US, the UK, and German governments co-funded, co-developed, co-own these vaccines. They need to march in, they need to assert their rights, and they need to ensure that there is a compulsory transfer of the technology so that we can scale up manufacturing fast enough. There is capacity, there is ability. With a minimal amount of investment in the mRNA vaccine technology, you could actually scale that up, and you could do that in the next 12 to 18 months. You don't necessarily have to wait 3 to 4 years to actually rely on expanded manufacturing capacity. So really the call has to be share the vaccine know-how, share the vaccine knowledge now. Thank you.
Thanks, Fatima. So that's how we are ending with that: share the vaccine know-how, share the vaccine knowledge. Now we have some time for questions. I've only got one question here, and we want to just really get these questions through because both of our keynote speakers, Fatima and Shabir, are going to have to leave us. And so the first question that I have here, and please either raise your hand or write questions here for this very short question and answer session that we have as I'm speaking. But a question from Jean-Michel Héraud to Professor Madi: in order to get countries more involved in planning vaccination strategies, we need more data regarding real burden of disease, in particular among at-risk populations. How would you see as the best way to offer countries tools to get these estimates? So Professor Madi, would you be able to answer that question?
Yeah, thanks, Tim. So I think that's a really important issue in terms of quantifying where we are. And that would also sort of influence what the need for COVID-19 vaccines is on the continent and in Southern Africa. The quickest way to do this is to do serious surveys. And that is something that has recently been undertaken in South Africa, where we'll be hopefully releasing some data as early as next week at the provincial level, and as well as allowing us to be able to get estimates at a sub-district level. So seeing whether there are geographic differences in terms of the past infection that's been taking place. So what the serious surveys are is something as simple as taking a dry blood spot. I think we're a good starting point for many of the Southern African countries, because most of them have indicated that they're planning on vaccinating healthcare workers as a start, would be to actually do those rapid serious surveys where you can literally get an answer in a matter of 1 or 2 weeks to be able to quantify what the past force of infection has been. Those sort of serious surveys are also especially useful in terms of being able to quantify what is known as the infection mortality rate. And the infection mortality rate, interestingly, in South Africa indicates that despite there having been a large force of infection, the infection mortality rate in South Africa probably is 1/3 compared to, as an example, in the United Kingdom. So the infection mortality rate in South Africa is sitting at about 0.3%, where the denominator is anyone that has been infected based on the sero surveys, whereas in the United States, United Kingdom, that's closer to 0.9 to 1.2%. So doing those sero surveys would be extremely useful whilst we try to get our vaccine programs into place.
Thanks, Professor Madi. I've got a question from Mulea Mwanayanda, who is an Amnesty International, and she is asking Professor Madi, what sort of preparedness is required for vaccine rollout? So it's a similar question, and then we have another one afterwards.
Yeah, I mean, I think we've just completely underestimated across the continent once again the huge amount of logistics that needs to be sorted out before you start deploying vaccines, especially when you're trying to target vaccinating 2/3 of your population. The planning for that sort of deployment of vaccine far exceeds anything that we've done in the past, including when we tried to do catch-up campaigns for polio and measles. It would probably take close on to 4 to 6 months just to plan for successful deployment of the vaccines. And what I fear is going to happen is that even when these vaccines do become available to the continent, those vaccines are going to be stuck in warehouses. So that is a responsibility of government. And I think we need to avoid believing that because we're successful with measles or polio vaccine programs, that the same thing is going to happen for COVID-19, where the scale of it is just multifold greater. So what needs to be done whilst we're waiting for vaccines, government need to start testing systems. They need to be putting into place systems and testing those systems to see how efficient they would be when it comes to rolling out these COVID-19 vaccines.
Okay, thank you very much for that. And again, it just raises the question, human rights organizations and activists have been calling for some time now for vaccine acquisition, distribution, the waiver, all of this type of thing. So preparation is necessary in countries, even when the vaccine is nowhere near. And I think that will be important for our conversations going on. Claire Anyangwe says we need to look at issues related to monitoring any side effects of the vaccine. For those who have received the vaccines, how have we incorporated this in support to governments? Pharmacovigilance will be primordial. And so I'll ask another question because there's a second one from Mulea now. And then I'll give it over to the speakers. Second question is, in the absence of capacity to manufacture, what should civil society be doing to ensure people get vaccinated? While calling for waivers may seem to be futile, what should we get governments to do? So I think that maybe the first one is better for Professor Madi and the second one maybe for Fatima, but I think that I'll leave it to you to see who wants to answer this question.
Yeah, sure, I'll let Fatima answer the second one. In terms of the first part, again, I mean, it's just really unfortunate that all of these issues are trying to be dealt with in the midst of a crisis. There's pretty much, again, a non-existence pharmacovigilance across the African continent, including in South Africa, where the pharmacovigilance for vaccines and other biologicals has been largely passive. To imagine that we're going to be able to set up systems to the likes of what exists and to what is required and that exists in other high-income countries. Unfortunately, again, it's not going to materialize in the short term. And I think we need to be cautious because we might well be able to set up systems which might be misleading rather than contributing in terms of understanding on the safety of this vaccine. So yes, pharmacovigilance is important, but I think we're forced into a situation where to a large extent, we're going to need to be dependent on places and pharmacovigilance systems that are in places where these systems have already been established. I think the important message, and this is something we should have learned in 2009, is that you don't plan for a crisis when a crisis is upon you. And it speaks to issues about the resilience of our healthcare systems.
Thanks, Fatima.
Thanks. So I think what we've noticed in the last few weeks, especially as the momentum around the TRIPS waiver has, gained some traction with a lot of support from more countries, is that there's this deliberate narrative to basically wrongly indicate that there's no manufacturing capacity and that there's very limited manufacturing capacity and that relaxing IP and patent monopolies and transferring the knowledge and capacity won't really help. And I think that's something as human rights defenders and activists, we really have to push back against, because that's what we were told when we were HIV/AIDS activists, when we were saying there is capacity and ability to scale up manufacturing of generic ARVs. So I think that, we have to be careful about the tricks that the pharmaceutical industry uses basically globally to try and suggest that IP is actually not the barrier at the moment. It is one of the single largest barriers. And I've spoken about some efforts in the US, particularly around the mRNA type vaccine technologies, where a little bit of investment could actually assist with scaling it up. I think the big issue currently globally and regionally, when you have scarcity, whether it's self-created or not, where you have limited supplies, is that how do you ration? And so the most important human rights question we're going to have to ask in the continent is, how are you going to ration limited supplies if they are only coming in 2021, 2022, 2023? And so where is the scientific consensus? For example, in the US, they have the National Academies of Science Expert Consensus Group. We need to find the scientific consensus for a public health epidemiological evidence-based argument for how you prioritize when you have scarce resources, so that we don't have the people who have medical insurance and the people who are richest and the people who are in the private sector jump in the queue. So our greatest concern right now with scarcity is, how do you ensure that people do not jump the queue unfairly or without any kind of public health evidence? We can't have a situation like we had with HIV/AIDS, where if you had money and if you had medical insurance, then you would access ARVs. But if you didn't have money and you didn't have medical insurance, then you just basically waited and waited and waited for the ability to get a CD4 test or a viral load test or an ARV. So I think this argument around the third way, where you ask pharmaceutical companies to sit around the table with you and voluntarily share technology, and they get to decide who the sub-license is, that's not going to work. We're in a crisis, it's a pandemic. We need to step up on the compulsory measures. And the irony is that African governments can make use of compulsory measures. They just have chosen for one whole year not to do that, because they're relying on the TRIPS waiver. And so in South Africa, for example, I think, Professor Mahdi is right to say that there are no timelines. We've been engaging with our government since November. We're saying, you keep saying you are negotiating with companies, and that there's a promise of 10 million here and 20 million there. Nobody's seen the contracts. We don't know when these supplies are landing, and we certainly don't know what price.
I don't know if it's for everyone else, but Fatima is a bit frozen right now. Could anyone else indicate to me whether it's just our side?
She's frozen.
Okay, unfortunately, Fatima is frozen. Hopefully we'll get her back soon. In the absence of that, the only other question that I had was about the TRIPS waiver, which I think is a better one for Fatima if we eventually get her back. But I've got a question for you, Professor Mahdi. Professor Mahdi, a lot of what we're trying to do here is coordinate regional and sub-regional strategies with neighboring countries. Now, in Southern Africa, there are some countries that are in a better position when it comes to access to vaccines, and those include countries like Seychelles and South Africa and Mauritius. What do you think that these countries can do to support vaccine access in our neighboring countries in the SADC? And after that, we'll come back to Fatima with the last questions and then close the session.
Yeah, so I mean, so countries such as Seychelles or Mauritius, they probably have gained access to vaccines through bilaterals rather than a dependency on a COVAX facility. And as has been pointed out, for small countries to try to negotiate small quantities of vaccine, you're pretty much uncompetitive. And that's one of the reasons why South Africa, as an example, ended up paying double the price for AstraZeneca vaccine compared to the EU. So we're in a difficult situation. And I think, again, what I would like to emphasize is that the current generation of vaccines are not vaccines that we need to target vaccinating 2/3 of our population. There's very little that's going to be gained from that. The current generation of vaccines really need to be focused in terms of preventing severe disease and death. And for that to happen, if we can gain access to the 20-30% of vaccines which countries are expected to get to the COVAX facility, we would be able to achieve that sort of target. So there needs to be a recalibration in terms of what we expect of the vaccines and the recalibration in terms of who we're wanting to vaccinate and for what purpose. I don't think, unfortunately, those countries that have been successful through bilaterals to get vaccines for their own countries are going to be able to provide much assistance to other neighboring countries simply because the manufacture of there's constraints in terms of the quantity of vaccines is going to be available, at least for the next, into the last quarter of 2021.
Thanks, which again highlights the reason why bilateral agreements to obtain vaccines is one of the big problems that we have to deal with, and also might help contribute to ideas that we might use as advocacy at the SADC level to try and do things a little bit less bilaterally or more collectively. But thank you for that, Professor Mahdi. Then we've got last questions for Fatima, who I believe is back. So the first one is from Tanvir. In practice, what are the incentives for countries who have already secured necessary vaccine doses for herd immunity to back the TRIPS waiver? And what should civil society do in those countries? And then the second question on that is that the TRIPS language talks about the rights of states to exercise flexibilities. It doesn't talk about the obligations of states to exercise flexibilities. And this is coming out in international resolutions of the Human Rights Council too. And it's a problem because as human rights activists, we generally try and focus on what the state is obliged to do. Does this signal a bigger weakness in the interaction between global trade law and international human rights law? So those are the two questions for Fatima, and then I'll invite both of you to make any concluding remarks you want to. Fatima, maybe add any concluding remarks you want to make onto this answer, and then I'll go back to Professor Mahdi.
Thanks. So, and I do apologize, you can blame every host for that. But I am back. So I think Tanvir's question is an important one. What is happening around the world actually is groups, for example, in France, in New Zealand, in Australia, civil society and trade unions are actually asking their governments to justify why they are blocking the waiver when it's perfectly permitted within the rules of the WTO, including flexibilities around the Doha Declaration. So I think what we are quite surprised by as activists and people working in the IP space is that the mechanism that is being suggested is actually permitted by the WTO. It's permitted by the rules. So it's a very rules-based, rule-bound system. And so it's really unbelievable, and I think also inexplicable that richer countries that are vaccinating would block it. What we do know, and which is why I showed you the tweet in relation to some of the front-runner vaccine companies who are very forcefully blocking the waiver. So they've written to the US Trade Office indicating that the UN, the WHO, UNICEF, all of civil society, everybody should be basically sanctioned for even calling for a TRIPS waiver. So there's something fundamentally wrong and I think Tanvir is right about the way in which trade rules operate, that preferences, the power and the might of a handful of multinational companies over what governments believe. We know bilaterally they're indicating they support the waiver, but they can't publicly say that, and they can't, sort of exercise that particular mandate at the TRIPS, at the WTO, and that's why I think it's interesting that the new DG, who actually comes from Nigeria, the new DG of the WTO is now talking about a third wave, which still relies on voluntary measures. So there's, like we saw with the HIV/AIDS crisis, I think there's certainly a concern around wanting companies to exercise total control in a pandemic. We've previously argued that they're basically acting like God in a pandemic, and that one day we'll be able to write the books on this pandemic and show that their conduct actually contributed to premature suffering and premature death.
Thanks so much, Fatima. Professor Mahdi, any closing thoughts?
Yeah, so I fully agree with Fatima that it's important for us to take up these challenges around intellectual rights. But at the same time, I think we need to guard against being over-optimistic in terms of what can be achieved in a short period of time. The reality is that to set up manufacturing facilities from scratch is a 2 to 3 year program. And by that time, you can be rest assured that there'll probably be sufficient manufacturing capacity outside of the continent, as well as most likely we would have reached the state of community immunity, which makes it less urgent to vaccinate large numbers of individuals. So whilst it is a justified cause and an important cause, that is not what is going to get our populations protected against the virus during the course of 2021. And again, just to emphasize, we need to really rethink what we want of these vaccines. And if we become more targeted in our approach, I think the opportunity exists, be it through the Commonwealth Initiative or be it with bilateral, or rather engagement as a bloc with countries which have oversubscribed to vaccine. We need to start seeing how we can engage with those countries to start providing access to that vaccine which they've oversubscribed to, not when they've vaccinated 80% of the population, but as soon as those vaccines actually become available to them. For many of these countries, including Canada, the United Kingdom, they're going to have more vaccine that they're going to be able to deploy very soon. So those discussions with those countries need to be engaged with. so that we can see if we can at least gain some level of access to that additional vaccine which the countries have committed to purchasing.
Okay, thank you. At this point, I'd just like to say thank you very much to both Fatima Hassan and Shabir Mahdi for your very generous contributions today. And if you need to go off, which I understand both of you might need to do, then please feel free to do so. And we will definitely be looking for your guidance as we plan forward to do advocacy. But I think that both of you have really given us a good overview so that when we go into the minutiae of the detail on particular countries within the SADC, we will be in a good position to have a discussion going forward. So thank you very much for both of you for your keynote presentations. So now I'd just like to check before I say my final comment. Arnold from Oxfam, are you there? Are you ready to take over the moderation?
Yeah, yes, I'm there, Tim.
Okay, so while I transition to Arnold, so we're splitting the moderation. So Arnold is going to take care of the next session. Let me just say that the purpose of this event was to actually start coordinating amongst different people from different countries. We've made a very, very large effort to get speakers from each individual country, both from a public health or health perspective and from a human rights defenders perspective. It's not been possible with all of the countries. As you'll see, we don't anticipate that there's anyone here to speak about Tanzania. That might not surprise you, knowing that Tanzania has adopted a denialist approach sometimes to COVID-19 and vaccines, and we're not quite sure exactly where their president is right now, and people are being arrested for suggesting that he might be in a hospital as a result of COVID and all of this type of thing. But we do have almost every single country from the SADC represented. And in the next section, the aim of what the session that Arnold will be convening and moderating is to hear more about specifically what's going on in particular countries about vaccine access. Hopefully, eventually, to plan towards coordinating efforts within Southern Africa and having alliances and coalitions to improve vaccine access in the whole sub-region. So with that, thank you very much. And I'm handing over to Arnold now for the remainder of that session with specific country speakers.
Okay, thanks, Tim, for handing over and for the facilitation for the first part of the symposium, and quite illuminating and interesting points that have been made by all the keynote speakers, as well as the opening remarks that have also framed our perspective around the vaccine from the perspective of inequality and human rights, which is something that is quite important. So at this point, we'll also want to get a chance to listen to our different speakers from the different countries, as Tim has pointed out. And the main purpose for this is to also get a sense of what has been going on within the countries in terms of the vaccination and what the experiences were. And we hope that from sharing those country experiences, we'll then be in a position to come up with a practical strategy or practical next steps on how we can also work together and put more pressure both within countries at a regional level and where possible at a global level, just to ensure that there is equity in the vaccination program, and also human rights standards are also upheld during the vaccinations. So I'll just go through the list of people, and then hopefully when I call out the names, they can also come forward and share perspectives, at least 2 to 3 minutes, 3 minutes maximum, since we have quite a couple of countries that are present. So let me just go back to the list and see who is our first speaker. So do we have Dr. Dek Shaka from the Democratic Republic of Congo? Okay, so if Dr. Dek Shaka is not yet in or not yet ready, we can move to Mary Da Silva from Eswatini. Is Mary present to give a few remarks, a few perspectives?
I see Mary online. Mary, I think you're muted if you're speaking. There you are.
Yes.
Yeah, you can go ahead, Mary.
Yes, thank you. Good morning, everyone. I have been introduced, I am Mary Da Silva. I am from Swaziland. I also work as the Gender and Social Inclusion Advisor for the Southern Africa Human Rights Defenders Network. And the issue of vaccines has been discussed within our institution as well, so it's not a new one. Now, on the issue of Eswatini, we have a government that is non-responsive and non-consultative in their approaches. At present, the only information we get from government is because of any pushbacks that may come from the public or civil society with regard to their plans. What we do know is that they issue a press statement at the beginning of February where they sort of gave us a small brief snippet of what the rollout would look like. They just basically said it would be done in 3 phases. The first phase would take care of health workers and frontline workers, which would only take care of 3% of the population. The second phase would be on elderly people who are 60 years and above, and people living with comorbidities. That would only take into account 17% of the population. Then the third phase would be on communities that are unable to practice social distancing and travelers. But what they have not said is exactly what it means for communities that can't practice social distancing, what criteria would be used, and for travelers as well, which travelers would be vaccinated. Would it be frequent travelers or just anyone that is leaving the country? That criteria also has not been clarified. And also they say that this phase will also take care of essential workers that are outside the healthcare. And again, the criteria is not very clear. And this third phase would only take into account 60% of the population. Now that gives us a picture that our government is only looking at 80% coverage by the end of 2021, which is their goal. However, in their plans at the very beginning of the vaccination discussion, they had indicated that they are looking at a 100% vaccination coverage for the entire population by the end of 2021, and that there is a budget that has been put in place of 200 million to procure the vaccines. Now, there is no clarity on where that 200 million has come from or how it will be, which vaccinations will be used with regard to whether it's going to be AstraZeneca or it will be Pfizer or any of the other vaccines that are out there. What we do know is that part of their plan is to use the vaccines that have been donated. Just last week, we had donations first from the government of India, who sent us 20,000 vaccines, the AstraZeneca vaccine. Then just a day or two later, we got 12,000 from the COVAX facility, which is 32,000, comes to about just less than 3% of the population. And this is the vaccine that they are proposing to use for their first phase. Now, there's a challenge with the first phase. Health workers are rejecting the AstraZeneca vaccine on the basis that, on the same basis as South Africa, that its efficacy against the strain that is prevalent in the country, the South African strain is said to be at 88% of prevalence in Swaziland. And so health workers are questioning the use of the AstraZeneca vaccine to say, if South Africa is rejecting it because of efficacy issues, why is Swaziland then continuing to use it? Especially since the government had indicated that what they will do is they are also rejecting the AstraZeneca after South Africa did that. They somersaulted just a week later to say they would still proceed to use it because that is what is readily available. And this gives us the indication that the government will be using what is readily available to them without putting in their own resources. So there's no public participation as evidenced by the outcry from the health workers. There's no public participation in discussions around the vaccines and the strategies around rollouts or any other policy for that matter. Now, something else that is glaring is that there's no provision for special provision for gender and social inclusion. There's no mention of women. There's no mention of LGBTI community. There's no mention of people living with disabilities on whether they will receive any preferential treatment or they will receive equitable access. That is very quiet. So for those that are outside the first phase, the health workers and the elderly, the first two phases and the elderly, if you fall within the gender and social inclusion bracket, it appears that you have to wait until the third phase has been implemented before we know whether they will have equitable access. There is no indication of whether the vaccines that are available will have any cost implications, whether people are receiving them free or whether people will have to pay an administrative fee or anything of that sort. What we do know is that the government has issued out a call for people to register to access the vaccine, and many people are refusing to register. There are very few people who are registering for this vaccine, and government is going to have to come up with another strategy to ensure that people are vaccinated. Now, the use of AstraZeneca is very contentious at this point.
Sorry, Mary.
Yes.
I think we've gone over the time.
Okay.
Yeah, my apologies. Yeah, so maybe in 30 seconds you can just wrap up in 30 seconds, and then we can also hear from Siso, who is also from Eswatini, to give frontline worker perspective.
Okay, so all I can say in terms of their rollout plan is just last week there was a team from Israel that came into the country to assist the government of Swaziland with a strategy. So that is clearly giving us an indication that government is grasping at straws. They have no strategy, and they're only beginning now to look at issues of logistics and assistance to healthcare workers. I think I'll end it at that. Thank you very much.
Yeah, thank you very much, Mary. So we also want to hear from Sibusiso Lushaba from Eswatini, so that she can give us maybe a perspective from the frontline workers. Do we have Sibusiso Lushaba?
I see her again here, but Sibusiso, you're going to have to unmute and turn your video on if you want us to hear you.
Thank you very much. I'm sorry, man. I'm actually traveling, but I'm not driving. Somebody else is driving, so I hope you can hear me. All right.
Yes,
yes, we can hear you. Thank you very much.
Okay. No. Yeah. I think Mary has actually laid a very good foundation in terms of what is currently happening in Swaziland or Eswatini in terms of access to vaccines. But I will just want to bring about the healthcare worker perspective, in particular the nurses' perspective. What we have seen in the country, first and foremost, is that there have been almost over 273 nurses that have been infected with COVID since March last year. So you can actually sense that there is a greater alarm in terms of the number of infections that are the surge in the number of infections among nurses in particular. So now, first and foremost, as healthcare workers were actually happy that a vaccine is going to be made available, as government announced that they are going to purchase 200 million vaccines in February, and after purchasing the 200 million vaccines, healthcare workers will be the first ones to be vaccinated. But then as an organization, we did a study, which is the Southern Democratic Nurses Union, whereby we found that only 38% of nurses are receptive to the vaccine, even before the issues around AstraZeneca and the issues around the South African variant, which proved to be actually resistant to AstraZeneca. So now, as we speak, the receptivity of AstraZeneca by healthcare workers is very, very low. Actually, the organization has actually said that it prefers that the country purchases Johnson & Johnson vaccine to ensure that the healthcare workers are actually protected, because it is clear that AstraZeneca is not efficacious against the new South African variant. So now there are some discussions around, ethical discussions around whether the healthcare workers will actually administer the vaccine to the population because of the issues around the efficacy, and also the issues that are coming out now, which are subject of scientific inquiry in terms of the blood clots, the issues of blood clots that have been seen in other countries who are actually vaccinating, and also the issues of other countries that have stopped using AstraZeneca. But in terms of preparedness, the healthcare workers are prepared to vaccinate the population. There are some strides that have been made in terms of making sure that nurses are trained to administer the AstraZeneca vaccine to the population. So I think basically what I can say, there's still some confusion, uncertainty around the issue of AstraZeneca, and generally low acceptability of the AstraZeneca amongst healthcare workers as we speak. Yes. So I think those are the main issues for us for the frontliners in the country, that we need to be protected, and we need a vaccine that will ensure that we are protected as we continue to give our services to the population of Eswatini. And I also want to appreciate the very informative presentations that were made by Fatima and Shabir in terms of the actual political economy of health, in terms of accessibility of vaccines in the world. And also, I think it is paramount for the African Union to make sure that countries like Ethiopia, South Africa, Egypt, Tunisia, who have capacities to develop a vaccine, are assisted to ensure that in the future, when there are pandemics, we as Africa can be able to produce vaccines, so that our people can be able to benefit in Africa. Yeah. So I think that is what I can contribute, Chair, on this part. Thank you.
Okay, thanks, Busiso. So I just want to jump to Dr. Edgar Mnazi, since he has a doctor's appointment in a few minutes. So Dr. Edgar Mnazi from Zimbabwe, you can just give us a quick update in 3 minutes.
Thank you so much, Dr. Chamu, for giving me this opportunity to contribute. Can you hear me?
Yes, we can hear you.
Okay, thanks.
You're a bit soft. If you can speak a bit closer to your device.
Okay, thanks. So I'm going to talk about the vaccine, COVID-19 vaccine rollout plan in Zimbabwe. The rollout plan started on the 18th of February after the government of Zimbabwe received a donation of 200,000 doses from the People's Republic of China. And up to date, which is 4 weeks, they've vaccinated about 39,500 people. And this is a bit concerning in terms of the pace at which the vaccination program is rolling out. There's a lot of hesitancy. There's a big mistrust of the government's processes. So I think there has to be some rethinking in terms of the strategy of how to revamp the numbers of people being vaccinated. The government did set up a panel of experts, which is called the National Coordinating Committee, to look at the available options in terms of the vaccines that can be rolled out in Zimbabwe. However, information or deliberations from this panel of experts has not been made public. We do not know, there's no evidence-based information in terms of why they have chosen to roll out the vaccines that have rolled out so far. We have the Sinopharm vaccine, and just yesterday the government received a further 400,000 doses from the Sinopharm vaccine again, and I think there's a bit of a mismatch. Some government officials are saying 200 of those that were received yesterday from the Novavax vaccine, but it is yet to be seen. However, I think the big major drivers of hesitance in Zimbabwe has to do with the contribution of some sects of the religious population who are castigating the vaccination program as an antichrist and the mark of the beast. So there's need to as a strategy to come up with, to have individuals in society that recognize or people can identify with it, because they do not really trust government officials. So I think going forward, we need to have people that people can identify with, be it musicians, particularly religious leaders, pastors, who are vaccine confident, to come forward and be vaccinated and be the champions in terms of spreading the message about the importance of people being vaccinated. If the rollout program for Zimbabwe continues at the same rate, it means to vaccinate about 600,000 people, it was going to take us about 15 months. To vaccinate about 3.7 million, which is the target for the first phase, it will take us 90 months. And we simply cannot afford this. Going back to what Professor Mahdi said about having vaccines in stock, running out of their shelf life, and also just hoarding vaccines without a proper strategy in terms of rolling out those vaccines. It's going to be a big issue in terms of equitable access. Already the vaccines are very difficult to come by. Many countries are waiting to receive their first doses. But if we are having vaccines expiring in stock without getting those vaccines in people's arms, then it's going to be really problematic. In terms of the groups that I believe Amnesty and ICJ and Oxfam can include in terms of advocacy, as the economy is being relaxed, I think there's need to rethink the strategy in terms of who we define as populations at risk, given that Zimbabwean economy is a highly informalized economy. There might be need to consider people like commercial sex workers, people like vendors, because of the sheer numbers that are involved in terms of the people that they interact with. These are likely to be areas where spread of COVID-19 will go and probably propagate the third wave that we are dreading, but hopefully we will not get to a third wave. But mainly, I think the big issue in Zimbabwe is the big issue of hesitancy. People are not coming forward to take the vaccines. So far the highest daily number of people being vaccinated was 3,800, and some days with as low as 76 people being vaccinated across the country. And this is simply, it cannot go like that. We need to come up with new strategies of inviting people, dealing with misinformation, dealing with vaccine hesitancy. Otherwise,
Dr. Mnazi, I might have to give you just 15 seconds to wrap up.
Yeah, I was actually wrapping up. So basically, those are my contributions in terms of coming up with new strategies in terms to invite people to come to get the vaccines, deal with vaccine hesitancy. Thank you.
Right. Thanks, Dr. Mnazi. Just to emphasize that, let's try and keep our presentations to a maximum of 3 minutes, given that we will also be having 2 speakers from one country. So now I'm calling on Anatoly Ginga from Angola. Do we have Anatoly in the... Yes.
Dizia que a realidade em Angola não foge do que os outros participantes já falaram, sobretudo os candidatos do SAI e também do Zimbábue. Nós perdemos a corrida do acesso à vacina e a única que recebemos foram 647 mil doses que vai incluir na primeira fase. Ok. Eu não sei, vou tentar me posicionar melhor, não sei se já me ouve. Pois, eu dizia que não fugíamos da realidade dos outros dois países, Zimbábue e Eswatini. Nós furtamos a corrida da aquisição de vacina e a que recebemos agora é uma doação da AstraZeneca por via da COVAX e recebemos 647 mil doses que foi planejada inicialmente para o pessoal de frente, que são os médicos, falou-se de polícias e professores, para posteriormente, numa segunda fase, vacinarem a população que tenha idades compreendidas de 16 a 39 anos. Ou seja, do plano que o governo nos traz, prevê-se vacinar apenas 52% da população. E, posteriormente, não nos dizem muito, não informam muito de como é que será esse processo. Por outro lado, o ceticismo da parte da vacina, que os outros contemporâneos também falaram, é muito visível também aqui. Eu não sei se, por termos criado um sistema de prevenção muito antecipado da Covid-19, levou exatamente à criação desse ceticismo, ou então por falta de confiança, né, em função dos relatos que têm ocorrido e dos outros elementos que a vacina traz. Se não, da parte do governo de Angola, há exatamente essas duas fases da vacina, ou do sistema de vacinação para a população. Há uma grande preocupação. Sabemos também que recentemente o Presidente da República entrou em corrida e conta a receber para a segunda fase, exatamente da população, da vacinação massiva, vacinas vindas da Rússia, a Sputnik e também do apoio da China. Então, continuamos todos expectantes à espera que exatamente esse programa dê certo, porque em Angola nós temos sérias condições de logística, temos sérias condições de acesso às localidades e acreditamos que a vacina vai ser simplesmente distribuída em forma de funil, né, para aqueles que têm maior possibilidade, para aqueles que vivem nas áreas citadinas, para aqueles que vivem em locais onde têm acesso, porque mesmo até os outros programas de vacinação, a população não tem chegado às zonas mais recônditas do país. Então, estamos a antever um processo de vacinação simplesmente para aquelas áreas onde se chega, onde há mais acesso por meio de estrada, e a população das áreas que não tem acesso talvez ficarem esquecidas ou ficarem desta maneira. Eu acho que termina a minha intervenção e dou acesso aos outros. Obrigado.
Okay, thanks Anatoly, and thanks to the interpretation team as well. So now I call upon Cindy Kelemi.
Arnold, sorry, I've tried to message you. Dr. Dirk, I think from the beginning, I think he might be in, so I'm not sure if you want to maybe check on him. Dr. Dirk Shaka.
Yeah, I was going to do so. Thank you, Mandiba. I was going to do so. So I'm just following down the list, and I was going to get to him in about 2 or 3 speakers down the line. Yeah, thanks. Do we have Cindy Kelemi from Botswana?
Yes, I'm here. Good morning, everyone. As indicated, my name is Cindy Kelemi, and I'm the Executive Director of the Botswana Network on Ethics, Law, and HIV/AIDS. And thank you so much to the organizers for giving us this opportunity to speak to what is happening in the country in terms of access to COVID-19. I think you all agree with me that COVID-19 has posed, I think, the greatest challenge to health equity in our lifetime. Issues around fairness, issues around justice are really problematic. Botswana, like many other African countries, and of course other countries in other parts of the world, we have been impacted negatively. And this has impacted on our economy as a country. You may all know that Botswana is an upper middle income country, but the COVID situation really has rendered us close to being one of the poor countries because of the impact COVID has had on our economy. The government is doing its best to come up with recovery plans, but it is a challenge because there are other competing priorities. COVID has also had quite a negative impact on our healthcare system. Some of the people that are currently losing their lives, we strongly believe from a civil society perspective that these people should not be dying. They are dying because our systems are unable to handle the pressure that is caused by COVID-19. There's also been an impact on human rights related issues. When we come to access, obviously, as you saw on the maps that were being presented, Botswana has not administered a single dose to anyone as we speak, including the president. So it goes to show how behind the queue we are in terms of accessing the vaccine. We recently, I think it's 2 weeks ago, a week ago or so, we received a donation from India, and that was only about 300,000 doses. So it goes to show you how we are challenged in terms of accessing the vaccine. We also, what we are happy about is that the government has announced that the vaccine will be made available to refugees, migrant workers, documented and undocumented foreigners who are residing in Botswana. That we think that it's a positive, but it's really problematic if you are saying, I'm going to give to everyone, yet there is no single person that has received the vaccine as yet. We are also having challenges with access to diagnostics. Reports from the community, especially people we are working with, are experiencing challenges with accessing testing for the virus. So that is a problem. If we are having challenges with diagnostics, then the issue is how then are we able to know the extent of our epidemic and how we are responding it and who is at risk and who needs more support in terms of maybe access to the vaccine. So we need to improve our monitoring, our tracking, and our reporting interventions. So far, it's very difficult. And also that the information that we are given in terms of reports comes very late. Sometimes it's 3 to 4 days, sometimes beyond that. So we need real-time data for us to be able to really monitor what is going on the ground. There have also been human rights challenges primarily posed by the legal environment. We have been operating under a state of emergency now for over 6 months. And that basically compromises the extent to which, especially civil society, can be engaged in the decisions that government is making. So because civil society is on the margins, therefore the voice of the voiceless, or should I say those who are not on the table, it means they are not represented, and that poses great challenges. We also have issues related to lack of a multi-sectoral response. Currently, it's Ministry of Health and the Office of the President that are primarily leading the process at the exclusion of other entities and sectors such as civil society. We strongly believe that if we are to play an effective role as civil society, especially in playing a watchdog role, ensuring that government is at least committing and ensuring that the vaccine is available to all, especially those who are vulnerable, civil society needs to be actively engaged. And linked to that, it's also the issue of information. It's very, very difficult to get information about what is going on, what decisions are being made, and so forth and so on. We would like to see a situation where the space is being opened a little bit for civil society to be able to play a greater role. And then the other challenge is preparedness to roll out.
Sorry, Cindy. Maybe if you can wrap up in 15 to 30 seconds so that we can also hear from Dr. Koketso, who is also from Botswana.
Okay, so we preparedness to roll out the vaccines. So far, government has said that because they have dealt with other epidemics, as far as they are concerned, they have the structures available and so forth. But what we are hearing at the moment is that trainings are ongoing in various districts to try and prepare cadres who are going to support the process. In our view, this is coming a little late because we knew the vaccines were coming in a longer period of time. We strongly believe that we should have been prepared more than we are. And then, of course, the issue of who is getting the vaccine first, that has been outlined. But from a civil society perspective, we feel that there are people who should form part of this first cohort, especially looking at people like teachers, community healthcare workers. So far, there are reports that over 24 teachers have died from COVID-19. So it renders them a key population or a vulnerable population, and therefore they should have access. Transport providers as well are some of the people that we had hoped that they would form part of the cohort that will be vaccinated from the beginning, but none of that is going to happen, at least in the near future. So what we are basically saying is that government needs to open up the space so that civil society can be actively engaged in the decisions that are being made, and also their community voice should be represented through civil society, which is currently lacking in our response. Thank you.
Right, yeah, thanks, Cindy. Can we have Dr. Koketso Majuta from Botswana as well? Is Dr. Koketso in?
Hello, can you hear me?
Yes, thank you.
All right. I'm struggling to turn on my video, but anyway, I'm just gonna go ahead with my talk. I think to appreciate what Cindy has been saying, basically I do agree with her. Basically, as Botswana, we are a bit lagging behind in terms of our preparedness to vaccinate our population. I think amongst the few that have at least already received their vaccinations, we haven't really done much. We do have access to the phases that the government has tried to implement. So basically, the government has proposed to implement the vaccine in 3 phases. The first phase, which is to strengthen the health system, which is basically targeted at vaccinating our healthcare workers and the frontline workers. And they have an estimated number of more than 160,000 as part of the phase 1 target group that needs to be vaccinated. And as yet, we have received 30,000 AstraZeneca vaccines as a donation from the Republic of India. But like CD has already said, our preparedness shows that we have not even vaccinated a single person. And today we had officials at the Ministry of Health launching a promotion for people to be ready to start being vaccinated. I think this is a response to a lot of the poor public confidence or the low public confidence as to the number of people that are willing to get vaccinated with the vaccines that we are expecting to receive. As you might be aware that Botswana, like other SADC countries, we are depending on the COVAX and donations from bilateral agreements for us to be able to access the vaccines that we want to roll out our vaccine program. Therefore, as yet, the commitments that we have are of the AstraZeneca, but because of the poor public participation of the government with other sectors of the healthcare industry and even the civil society, you have noted also, you have seen the Botswana Doctors Union issuing out a memorandum discouraging other people or its members from receiving the AstraZeneca, as it has not been shown to be very effective against the dominant strain of the South African variant. That shows that it's defeating our efforts in terms of, or the goal of vaccinating. I think if the government can come forward and include participation of healthcare workers as to their aims, which I believe rightly so, the aim for them is to reduce severe illness and death, which at least AstraZeneca vaccine has been shown to do. So that for the first group, for the phase of vaccination is what the government is planning to do. For the first phase 2, it includes those 65 and above without comorbidities, and the phase 3, which includes the 80% of the population, estimating at least 900,000 people. And from the look of the pool that we have with vaccinations, we already have 30,000 and we're expecting 130,000 from COVAX, which means by the time we receive COVAX, we'll only have enough vaccines to vaccinate our frontline workers. Therefore, it begs the question of how are we going to be able to access or to buy the remaining vaccines for us to be able to roll out the phases. So I think for us as a government or as health workers, we are very concerned about the poor planning in terms of how is the government going to purchase the rightful vaccines, and will they be able to buy them on time, and will we be able to vaccinate every single person that needs to be vaccinated. And also for some of us who are healthcare workers, we also are not aware of how the logistics are going to be involved for us to be starting to engage. Are we going to be charging people a certain fee for vaccinating them? And what is going to be happening? Already what we see in our facilities is that when it comes to diagnostics, those that can't afford, because of the surge of cases that we are having the few people that have low money to pay for their diagnostics. They can't afford to get their families. As from time to time, the government will have logistical issues into deploying or distributing the diagnostic test to regions outside the capital city. So in essence, I believe there is more that our government can do in terms of speeding up and accelerating the vaccine process, and also opening up the forum so that more healthcare workers or other parts of the civil community can be involved in the decision making towards ensuring that everyone won't be left behind well on time, so that by the time the third wave comes, as we're expecting it, at least we will have strengthened our health system, which is already under immense pressure. Thank you. I don't know if everyone heard me.
Yes, thanks a lot, Doc. So now we move to Frank Loba from Gavi, from the Comoros.
Oui, allô?
Okay, thank you.
Allô? Vous m'entendez?
Oui, on vous entend.
Oui, on vous entend.
OK. Bonjour à tous. Ici en Union des Comores, un peu comme pour tous les autres pays, pour tous les autres participants qui viennent de parler, on est engagé dans le processus COVAX pour une partie de la vaccination, en l'occurrence 20% de la population. Et comme la stratégie de vaccination de l'Union des Comores, c'est d'arriver à vacciner au moins 60% de sa population, les 40 autres % sont couverts par des achats du gouvernement ou par des dons qui sont faits par les partenaires bilatéraux. Et on n'a pas encore commencé la vaccination en tant que telle parce que c'est seulement aujourd'hui que les dons, une première partie des dons viennent d'arriver, et on attend les vaccins COVAX pour la première semaine du mois d'avril. Et cette stratégie-là nous permettra, comme je le disais, de couvrir 60% de la population. Et dans cette stratégie, on a surtout mis en avant l'équité de la vaccination. Pour les 20%, la cible,
Sorry to interrupt. On the English channel, we're currently hearing 2 simultaneous translations into English. I don't know if everyone else is getting it, but it's very busy. Could we try and resolve that? Sorry to interrupt you.
So the French interpreter speaks.
Je viens tout de suite.
Bon, ok.
Allô?
Oui.
C'est bon, la traduction, c'est réparti?
Pas encore. Sorry, can the French translate again?
I think let's try and proceed and see if it works now with one person translating into English on the English channel.
Thank you, Tim. I'll just speak to Mr. Loba. Monsieur Loba, est-ce que vous pouvez continuer, s'il vous plaît? Je pense que la traduction m'a...
D'accord. Comme je vous le disais en Union des Comores, l'accès équitable au vaccin a été une chose qui a été mise en avant dans la stratégie, dans la mise en œuvre de la stratégie de vaccination. C'est pour cela que les 20% de doses pour pouvoir couvrir 20% de la vont servir à
Should we try and move on to another country, Arnold, and then come back to Mr. Loba?
Hello?
Yes, Arnold, maybe we should try and move on to another country and come back to Mr. Loba when his connection is better.
Yeah, sure. We can do so. So can you move to Dr. Dek Shaka from the Democratic Republic of Congo? Dr. Dek Shaka.
Bonjour à tous. Je ne sais pas si vous m'entendez, s'il vous plaît.
On vous entend, oui, merci.
Yes. Yes, we can.
Bonjour à tous. Vous m'entendez, s'il vous plaît?
Oui, on vous entend.
Merci beaucoup. Je parle de la République démocratique du Congo. Le gouvernement de la République démocratique du Congo venait de recevoir le 2 mars le premier lot de vaccins qui ont été disponibilisés pour le pays dans le cadre de partenariat COVAX. Il s'agissait de 1,7 million de doses de vaccins AstraZeneca, qui, dans une provision de 6,9 millions de doses qui sont prévues par le gouvernement dans un plan de vaccination qui devrait couvrir 20% de la population. À ce stade, un plan a été aménagé par le gouvernement et consistait à pouvoir vacciner en priorité le premier groupe des travailleurs et des personnels de santé qui normalement représenterait 1% de la population cible. Ensuite, le deuxième groupe cible devrait concerner les personnes vivant avec les comorbidités, donc les personnes vivant avec le diabète, l'hypertension, les maladies chroniques. Et ce groupe devrait constituer 13% de la population cible. Et en troisième lieu, le groupe de personnes âgées de plus de 55 ans qui devrait représenter 6% de la population. Au-delà de ce plan qui prévoyait des groupes cibles par rapport à ce premier tour de vaccination, il n'existe pas un autre plan plus élaboré qui a été communiqué par le gouvernement dans le sens de pouvoir planifier la suite de la procédure de vaccination telle que cela pourrait concerner l'ensemble de la population en général. Alors, est-ce que le gouvernement n'a pas rendu public une quelconque campagne d'une stratégie pouvant permettre à la population de comprendre les aspects spécifiques du vaccin du vaccin AstraZeneca? Et cela pose un grand problème dans la compréhension, que ce soit des groupes cibles ou de la population en général vis-à-vis de la campagne de vaccination. Globalement, la population rejette processus de vaccination parce que cela est compris comme étant une menace et que cela pourrait constituer un danger pour les personnes qui pourraient être vaccinées. Le gouvernement a néanmoins éclairci sur l'accès gratuit à la vaccination. La vaccination ne pourra pas être conditionnée par un quelconque paiement. Cela a été communiqué de manière claire par le gouvernement, sans pour autant que cela ne puisse permettre une mise en œuvre d'une procédure quelconque de la collecte de données dans la suite, ou alors un mécanisme d'identification des personnes qui se montrent être favorables ou désireuses de se faire vacciner. En dehors de ces groupes cibles, aucune stratégie n'a été définie à ce stade, mais quelques structures médicales ont été indiquées comme étant des sites où les vaccinations pourront se tenir. Il n'existe pas non plus une stratégie gender qui permette de cibler de manière équitable la participation des différents sexes à ce processus de vaccination. Cela étant compris comme étant un acte volontaire, il n'a pas encore été spécifié les mécanismes par lesquels on pourra encourager les différents genres à participer, ou alors des groupes spécifiques à être prioritaires dans le processus de vaccination. Le personnel de santé lui-même se montre quelque peu sceptique quant à la vaccination, étant donné les peu d'informations qui existent et qui ont été mises à la disposition du grand public sur la qualité, les caractéristiques, les effets, mais surtout la question de la garantie sur les effets secondaires. La plupart de personnes demandent, en cas d'effet secondaire, qui est répondant? Est-ce la firme? Est-ce l'OMS? Ou est-ce le gouvernement? En cas de vastes effets secondaires qui seraient déclarés sur les populations, du moment qu'il n'y a pas un engagement qui est pris par les personnes volontaires, qui devra répondre des effets secondaires? Et cela est à la base de beaucoup de scepticisme, particulièrement auprès des personnels de santé qui semblent être informés et qui ont besoin davantage d'informations pour pouvoir non seulement éduquer d'autres personnes, mais aussi se porter volontaire à la vaccination. La désinformation est un axe très important parce que là où il n'y a pas d'information claire, la désinformation s'installe et on a davantage dans les réseaux sociaux des leaders d'opinion ou d'autres personnes qui demandent, par exemple, que ce soit d'abord le gouvernement, le président de la République et tous les autres, qui soient d'abord les premières personnes à recevoir le vaccin et que par la suite, la population générale ne pourra y accéder que si elle s'assure qu'il n'y a pas d'effet secondaire et qu'ils ont reçu le même vaccin que les autres. Donc, il y a une forme de désinformation qui est très forte et qui prise de cet élan de vaccination auprès de la population. Pour terminer, le gouvernement n'a pas annoncé donc un plan large de vaccination à ce stade et donc la société civile n'a pas particulièrement été associée à une démarche quelconque de vulgarisation ou alors d'implication de la masse de la communauté dans ce processus de vaccination à venir. Il est donc important, si certaines barrières doivent être levées, comme ce fut le cas lors de la riposte contre le Covid, d'améliorer le processus de communication, mais aussi de pouvoir répondre aux questions cruciales, aux questions critiques que la population se pose, et surtout les personnels médicaux et les autres qui sont en première ligne dans le processus de vaccination, afin de répondre aux préoccupations de la société et de permettre donc un meilleur accès et une meilleure acceptabilité de la vaccination par la population en général. Merci en bref, ce que je peux dire. On pourra revenir lors des questions. Merci beaucoup.
Okay, thanks a lot, Doc. So now Frank Loba has switched his connection. So can we have Frank Loba from Gavi?
Merci à vous. J'espère que vous m'entendez mieux maintenant.
On vous entend très bien, merci monsieur.
D'accord. Une petite précision. D'accord. Je travaille pour Gavi en qualité d'assistant technique ici en Union des Comores. Donc, comme je le disais tout à l'heure, les problèmes qui sont évoqués ici sont similaires pour tous les pays. Donc, je ne vais pas revenir sur tous ces problèmes qui ont été évoqués, mais je vais juste dire un peu, partager mon expérience, notre expérience ici en Union des Comores. La communication est un facteur important pour la réussite de ces campagnes de vaccination-là, parce que comme le disait M. Chaka tout à l'heure, un manque de communication entraîne une susceptibilité de la population quant à l'acceptation de ces vaccins-là. Et ici, on a déjà commencé à déployer un large plan de communication avec tous les partenaires de l'Alliance Gavi et les partenaires aussi du COVAX, notamment l'OMS et l'UNICEF, pour pouvoir sensibiliser la population quant à l'acceptabilité des vaccins. Pour ce qui concerne l'équité, on a, avec le plan national de déploiement des vaccins, on a adressé dans un premier temps les 20%, qui est le classique pour tous les pays, là, et on a adressé dans un second lieu 40% de la population. Et ces 40%-là, on a essayé de mettre en avant les populations défavorisées qui ont un accès difficile aux services de vaccination. Donc, différentes stratégies pour pouvoir atteindre ces populations-là seront déployées au moment de la vaccination. Aussi bien la vaccination porte à porte, les stratégies avancées et puis les stratégies mobiles pour pouvoir les atteindre. Et ce service de vaccination-là est gratuit. Et pour que les gens soient réceptifs à cette vaccination, il est prévu de faire un lancement avec les chefs religieux, les autorités politiques et religieuses et les leaders d'opinion pour augmenter le niveau d'acceptabilité de la vaccination. La cible que le pays s'est fixée, c'est déjà de vacciner à peu près 60% de sa population, ce qui représente un peu plus de 400 000 habitants, un peu plus de 400 000 habitants, mais on espère aller au-delà pour pouvoir atteindre ce qu'on appelle globalement l'immunité collective, qui est un thème que Dr Hassan contestait tout à l'heure, mais au moins vacciner 70% de la population pour être sûr que cette population-là, en cas de résurgence d'une nouvelle vague, puisse être à l'abri et que les dommages puissent être atténués, parce que je vous avoue que l'insularité est un facteur de multiplication de la contagiosité de cette maladie-là. Alors, je pense avoir partagé un peu ce qui se passe ici en Union des Comores et je suis disponible éventuellement s'il y avait des questions de manière spécifique pour avoir un peu plus d'informations sur ce qui se fait ici dans le cadre de la lutte contre la COVID-19. À vous, merci.
Thank you very much, Frank. Can we move to Dr. Mapane from Lesotho? Dr. Mapane from Lesotho.
Yes, sir, I'm here. Good day, everyone. Can you hear me?
Yes.
Can you hear me?
Yes.
Okay, thank you. Good day, everyone, and thank you. It's a privilege to be part of such a great initiative. I'm Dr. Matibela Mapane from Lesotho, and as been alluded to by everybody else, we have been affected as a country markedly, especially because during the peak of COVID-19, which was last year, our government had to be changing governance, changing from one prime minister to another. So financially, we got restrained a lot. So thanks to the COVAX facility for the support in ensuring that Lesotho can have access to the vaccines, although with limited supply, which the target was just 20% coverage of the population. And this led us to having an allocation framework with targeted priority groups. And just like in any other countries, our target groups, we had to have 3 phases. This one covering the health workers and those comorbidities, as well as those aged more than 60 years. And then we also applied to the AU Advanced Procurement Committee for additional vaccines, because our target group was actually 60%. So in this phase 1, we had over 430,000 people that we had to cover, 35,000 of which were actually health workers. So where are we now? We received the first batch of vaccinations 2 weeks ago, and from our phase 1 group, we had the health workers, but when the vaccinations were received, they actually covered the royal family, the head of state, the government, the politicians were the ones that received the first part. And then later on, it was given to the health workers. And the sad part is that the vaccination that we had received, although we expected 20% coverage, we only received 0.8%, which is already not enough just for the health workers, let alone the other groups that are already our priority groups. So currently, the vaccinations are in progress, and the vaccine that we have in this country is AstraZeneca, which we're having issues with efficacy as well. As Lesotho, geographically speaking, it's basically in South Africa. So if the strain in South Africa is resistant to AstraZeneca, it means we're also suffering the same problem. So the government also tried to have an app trying to find the views of the health workers on this vaccination. We're still waiting for the full report to see how we have responded as the health workers. But the general community was really not happy with the vaccination that we have. And also the other issue, the feasibility now. How feasible is it that we'll be able to cover 60% of the population if the country doesn't have COVID-19 budget as we speak? Because the budget that we had initially, which was last year, vanished into thin air as we speak, is still in the court of laws. So as the community, we are at stake. We don't know if we will eventually receive the vaccination, but that's where we are in the country. Thank you.
Okay, thanks a lot. So we can move to Mpho Maema from Lesotho as well. Okay, I noticed that Mpho, is Mpho on the call? Okay, so we can move to Honi Radet from Madagascar.
Oui, bonjour et merci de me donner la parole. Je suis issue de la société civile et pour nous, en fait, le cas est différent. J'aimerais préciser que pendant l'année 2020, quand on a eu la première vague de Covid-19, notre gouvernement a mis en avant un remède local basé sur l'artémisa qui s'appelle le CVO. Et il a vraiment appuyé toute sa campagne de riposte contre la Covid-19 sur ce produit. Voilà, ce CVO. Et quand en novembre 2020, nous devions donc, il y a eu l'appel à adhésion au mécanisme COVAX, notre gouvernement a refusé d'adhérer au mécanisme COVAX en mettant donc en avant l'existence de ce produit et en disant qu'on s'appuierait donc sur ça pour notre protection. Et hier encore, le ministre de la Santé avait un peu nuancé ses propos en disant que le pays d'État n'était pas contre la vaccination, mais qu'on était donc en phase d'observation de ce qui se passait au niveau international par rapport à l'utilisation du vaccin. Mais il a mis en avant donc le fait que l'AstraZeneca était suspendu dans quelques pays et il a mis en avant l'existence de ce remède qui se décline aujourd'hui soit en tisane, soit en sirop, soit en gélule. Ce que j'aimerais appuyer, c'est que pendant tout le processus de riposte contre la Covid-19, il n'y a pas eu d'inclusivité des différentes parties prenantes. La société civile, le secteur privé, nous n'avons pas été impliqués dans toute l'élaboration de la stratégie de riposte, dans la mise en œuvre, dans les prises de décision. Et ce qui fait qu'en novembre 2020, quand on a voulu au niveau de la société civile organiser un débat public pour que les citoyens soient informés sur les avancées par rapport au vaccin, le fonctionnement du mécanisme COVAX, la décision prise par le gouvernement de ne pas y adhérer, nous nous sommes heurtés à des refus. Des refus aussi bien de la part de l'État pour participer à ce débat, mais aussi de la part des partenaires techniques et financiers. On n'a eu qu'un seul partenaire qui était partant, mais sous réserve qu'un autre partenaire technique et financier participe à ce débat, ce qui fait qu'on n'avait pas pu le tenir. Aujourd'hui, à Madagascar, on est en train d'affronter notre deuxième vague. Et c'est un mot que le gouvernement, d'ailleurs, se refuse à utiliser, mais on constate que les cas augmentent et qu'il y a des cas plus virulents qu'avant. Et aujourd'hui, on commence à avoir des voix qui s'élèvent pour l'accès au vaccin. Il y a une pétition qui a été mise en place par une citoyenne depuis une semaine, qui est encore assez discrète, mais qui a déjà le mérite d'exister. Il y a aussi quelques politiciens, quelques partenaires techniques et financiers, mais le nombre se compte encore sur les doigts d'une main qui se sont manifestés, qui se sont exprimés pour l'accès au vaccin. Et du côté de la société civile, nous avons aujourd'hui, dans un premier temps, essayé d'approcher le ministère de la Santé, qui a été resté quand même assez hermétique ces derniers temps, hein, depuis que la pandémie de Covid-19 est là. On a réussi à avoir un rendez-vous cette semaine. Nous allons enchaîner sur un communiqué sur la riposte en général pour qu'elle soit beaucoup plus inclusive, beaucoup plus transparente et beaucoup plus redevable, mais aussi on va insister sur les vaccins pour que l'on puisse accéder à ces vaccins. Et c'est vrai que là, si on pourrait avoir un appui des organisations de la société civile au niveau international pour un plaidoyer plus efficace, ce serait vraiment utile et opportun et important, vital pour la population. Je vous remercie.
Right. Thank you very much. Can we move to the next speaker, who is Jean-Michel Herold from Madagascar as well? My apologies for the pronunciation.
It's not so bad. I will talk in French also, donc I'll give you a few minutes. Bonjour, merci pour l'invitation. Donc, je précise que donc j'ai travaillé de nombreuses années là maintenant. Je suis basé au Sénégal, mais c'est vrai que j'ai travaillé dans le secteur de la santé publique et la virologie pendant plus de 10 ans. Et j'ai donc dû répondre à beaucoup d'épidémies qui ont touché le pays et participé à des plans de riposte pandémique préparatifs. Donc c'est peut-être à ce titre-là qu'on m'a quand même demandé d'intervenir, connaissant bien la situation sanitaire à Madagascar. Je remercie donc l'intervenante Ouni qui a bien résumé, du coup ça m'évite de revenir là-dessus, la situation avec effectivement ce langage porté par les autorités sur la promotion d'un remède qui n'a pas démontré scientifiquement son efficacité. On attend toujours les résultats scientifiques, mais et à l'inverse, donc pas du tout d'inscription à l'agenda pour une vaccination, et ce, avant même qu'il y ait les problèmes d'AstraZeneca. La situation d'AstraZeneca ne fait que, on va dire, renforcer la stratégie de communication qui prévaut dans le pays pour dire, bon, ben voilà, on a bien fait d'attendre, regardez ce qui se passe, alors qu'en fait, dès le départ, il n'y a clairement pas de stratégie de vaccination. Pourquoi ça reste un mystère? La décision, ce qui est peut-être plus inquiétant, c'est que la décision de ne pas s'inscrire dans un processus de vaccination ne s'est pas basée sur des consultations de la communauté scientifique, de la communauté médicale et comme il a été précisé par Ouni, de la société civile. Dans la société civile, j'irais même aux leaders religieux qui, on le sait, à Madagascar, ont un rôle très important et leur voix, il y a un silence assez incroyable à ce sujet, de la part même des partenaires techniques et financiers. Donc ça, c'est ce qui est, je dirais, le plus inquiétant, que ces décisions soient prises sans qu'il y ait vraiment des consultations. Et même donc les essais cliniques qui sont utilisés à l'heure actuelle ont reçu l'agrément de l'Académie de médecine, mais après, on va dire, un rappel à l'ordre de la part du gouvernement. Donc voilà, c'est un peu la situation. Je pense que j'ose espérer qu'en tout cas que ça changera, puisque vu la situation de cette deuxième vague qui ne dit pas son nom, on observera donc au sein de la société civile un regain d'intérêt à la vaccination, et je crois que le pays ne va pas s'entêter dans cette ce serait l'obscurantisme, mais en tout cas de ce refus d'adhérer à un plan de vaccination. À l'heure actuelle, difficile de parler d'une stratégie vaccinale et d'un plan puisqu'il n'en existe pas. Je pense que malgré tout, le pays, une fois qu'il adhérera à ce principe de vaccination, adoptera malgré tout les standards qui sont utilisés dans les autres pays, à savoir la vaccination des agents de santé, les healthcare workers et les populations à risque. Encore faut-il définir ce qu'est une population à risque à Madagascar, puisque malheureusement les données relative sur le poids, et c'est la raison de ma question, docteur m'a dit, le poids réel de la maladie Covid à Madagascar est peu connu. Alors, même si des chiffres peut-être circulent de façon non officielle, en tout cas ne sont pas publics et qui tendaient à croire qu'en fait les effets du Covid sont plus importants que ce que laissent penser les chiffres officiels, non pas par peut-être un refus de les diffuser, mais sans doute peut-être par un manque d'habitude de ce genre de données, d'estimation du poids de la maladie. Donc, moi, je pense qu'il est important, je rejoins ma collègue de ONI, qu'il y ait plus de plaidoyer, aussi bien de l'extérieur que de l'intérieur du pays, de la société civile, des partenaires techniques et financiers, qui ne donnent pas simplement un chèque en blanc pour la riposte, mais qui est quand même vraiment une volonté d'un plan réel pour combattre cette maladie à tous les niveaux, aussi bien le confinement, alors quand je parle de confinement, enfin, la diminution du nombre de cas et qu'une stratégie de vaccination. Je pense que ça, c'est important et peut-être une piste, j'en ai parlé au tout début de mon intervention, reste les leaders religieux qui ont quand même vraiment un rôle important. On parle même de certaines personnes que l'on souhaite être nommées comme prix Nobel de la paix. Je pense que ce genre de personnes pourraient avoir un poids important, en tout cas, pour essayer de convaincre les autorités d'être plus claires, en tout cas, sur leur stratégie vaccinale. Voilà, j'ai terminé, je vous remercie.
All right, thank you very much. So now we can go to Prof. Roma Chilengi from Zambia.
Thank you, Chair, and thank you to the organizers. Am I audible enough?
Yes, it's audible. Thank you.
Okay, so my name is Roma Chilengi. I am a professor of vaccinology. I've been working in evaluating vaccines for the last 20 years. And in this instance, I have the opportunity to serve in support of the Ministry of Health on the National Immunization Technical Working Group. And recently we've been focused on COVID vaccines introduction, and I've been part of the teams that are making recommendations to government. I think the background to COVID situation in Zambia is not news to everybody. I think we know that the numbers of cases diagnosed in Zambia are only next to South Africa. And indeed, we recently also confirmed that the famous South African variant strain has been picked up here in Zambia. And we think that it's probably contributed to the increased morbidity in the second wave of the COVID outbreak. At the moment, there are active plans going on as recommended by the production. Like everybody else, I'm setting the prioritization warrants no discussion, because the intention is to get our frontline healthcare workers, then those with comorbid high-risk conditions, and then the rest of the population. But the approach for vaccine introduction is largely driven, obviously, by the expected access through the COVAX platform, as well as the African Union. And the information we last had was there was offers of vaccines through these platforms that had various amounts. And then just at the point when we were making recommendations in prioritizing which vaccines, the news that South Africa had halted, use of the AstraZeneca vaccine because of its low efficacy against the South African strain, that kind of threw us back to the drawing board. We've been at the drawing board for a while now and have made recommendations to the ministry. We are waiting for a cabinet decision about this. We are told that there is a specific budget that will support vaccine introduction. How much that budget is and what is holding it up, we don't know. But it does seem clear that the hinge of the whole vaccine introduction program is on the offers made through the African Union for a start, and get up to 20% of the workers first. But as you would recognize, I think current information is indicating that you need to vaccinate really between 65 and 70% of the adult population to achieve herd immunity. So even at best, if the targeted 20% of the population was vaccinated, we still have a huge gap in terms of achieving herd immunity. I think that the title of the symposium, in my view, should have been appropriately Inequitable COVID-19 Vaccine Access rather than Equitable Vaccine Access, because the inequities that we see with COVID vaccines continue to be exactly the same as it has been for a century. We always knew that traditional vaccines, once they were discovered and started to get in public use, they took anything between 15 and 20 years before we saw them used in routine practice in most African immunization programs. And unfortunately, with the COVID vaccine, despite very good technology to develop and test vaccines within a matter of months and produce them, we are way behind as Africa. So I think that to conclude my 3-minute talk, I would like to say that while this is a humanitarian issue, it is also very much a development issue. Wealthier countries rightly need to be and yes, IP-related issues wake up, and they need to be pressed equally because they need to ensure that there's sufficient attention given to research and development and protection of their people. I think that while we should press very hard on the humanitarian front, we do need to press the African government on their responsibility to take care of their people. I would like to end here, and fortunately, the COVID epidemic has not only targeted the poorest of poor. We've had even political leaders, a lot of them actually suffer from COVID, and unfortunately here in Zambia, even a couple of them at least passed due to COVID infection. So the situation in Zambia is no good news at all with regard to access to COVID vaccines. And we hope that these efforts will yield something tangible. But I insist that the African governments also need to be pressed. I thank you for listening.
All right. Okay. Thanks, Prof. So can we move to Dr. Francis Mpeta? Are you in the room? Dr. Francis Mpeta. Okay, so we can move to Malawi. George Jobe.
Thank you very much. Sorry, I am using two gadgets. One is able to capture my image and the video, and the other one does not have a camera. I am George Jobe. I work with the Malawi Health Equity Network, which is an alliance of over 90 civil society organizations. Then regarding Malawi, it is one of the beneficiaries of vaccine. And according to the information that we were given, it is the targeting 20% of the population. However, as it was said earlier on, what we have received is 300 something vaccines, which are below the 20%. Verbally, during briefings, the Ministry of Health told the nation that the percentage will go to 60%. Regarding a plan, Malawi has a plan which has been shared, and as Malawi Health have been shared electronically, different partners participated in the development of this plan. The vaccination is free at the point of access, and the one just needs the national identification as well as information on gender is captured. We are not sure whether race is part of this, because the rolling out has started, but as the civil society organizations, we have not participated in monitoring what is happening. Let me also mention that the vaccine came to Malawi on the 5th March, and the vaccination was done on the first vaccination was done on 11th March. The plan was to roll out on 15th, but it was pulled backwards. The first people to receive the vaccine were the state president and vice president of Malawi. The priority groups, as the other countries have shared, are healthcare workers, like frontline workers, including healthcare workers, the elderly, and the people with some healthy conditions. The vaccination card that is capturing data. As I said, we have not yet gone to some of the sites to monitor what is happening. Training has been done to some healthcare workers on how they can conduct the vaccination, and we believe they have been given protective equipment. Of course, just today we received information that in one of the districts they don't have fuel to move around. This is Rombe, and it is very surprising to us. One thing that we know is there has not been adequate information given to the public, especially to answer their questions, and they also address misconceptions and myths. And some of them go through social media, but no response has come. As other countries have said, issues surrounding AstraZeneca, which is the choice of Malawi. Why was it chosen? Civil society organizations do not know, do not participate. We don't know why. And probably it is because of the cost. Then what happened in South Africa has also had an impact on Malawi. Some people not trusting AstraZeneca. Then recently, the blood clotting issue in Germany and the Netherlands, people needed a voice of government on what it means. And we have seen that there's not much of talk from pharmacy experts. We have the Pharmacy and Medicines Regulatory Authority. It has not come out to dispute some of these. Mostly it has been government officials, and some of them are politicians. So misconceptions are one of the biggest challenges to Malawi. Much as the initial demand was 20%, but with the president receiving the vaccine and the vice president, we have seen some people asking how they can access the vaccine. However, we don't think there will be a lot of supply to meet that demand. There's need for more advocacy. Advocacy so that government must put the resources to this. At the moment, we are just relying on donors. We know for the COVAX facility. There's need for advocacy so that the government and the experts come out and answer questions to the public. especially on efficacy and the blood clotting issue. And in Malawi also, it should be appreciated that COVID-19 has been one of issues in politics, because when COVID came last year, we were undergoing political campaigns, and until now, COVID-19 is a political issue. So that is also where we need to be engaging more government through advocacy. There's need for more awareness raising and monitoring what is happening. Monitoring the effects after vaccination, and monitoring also protective equipment for our health care workers. So media can be involved, and including community leaders, chiefs. Probably when people can hear from their chiefs, from religious leaders, they can trust them more than when they hear from politicians. That's the experience we had in 2020, when ministers came to the podium and talked about COVID-19. People had less trust, but we have not drawn lessons from that. We are continuing to do the same. We are seeing more of politicians addressing the nation. So thank you very much. That's the end of my sharing of information.
Okay, thanks very much, George. Can we move to Makumbo Mtali? Do we have Makumbo Mtali? And can we try to keep it as much as possible at 2 minutes, so that we can also have others sharing their experiences?
Thank you so much. My name is Makumbo Mtali. I'm representing Malawi Human Rights Commission, which is a national human rights institution founded by Section 129 of the Constitution of Malawi. I had prepared a presentation, but what I'll do, I'll only focus on the COVID-19 rollout in terms of what are the current issues. And I have to agree with Mr. Jobe from Malawi Health Equity Network that I think the number of issues that he has raised, which I totally agree with him. I think when you go in terms of the key highlights, let me just quickly, on the rollout, Malawi has indeed received 360,000 doses, and we have also received from the government of India, I think an additional that is around 50,000 doses. And then the African Union has also come in with 100,000 doses. So I think at the moment we should be talking about 510,000 doses. But as Mr. Job indicated, I think the target is 20% under the first phase. And I think there's been an issue around the Malawi also going outside the COVAX facility contribution, because I think that one will only cover a small percentage. I mean, just targeting around 3.8 million, yet there are still 7.2 million that still need to be covered. So I think the issue around how the government will access resources to cover for the remaining 7.2 million will be critical. I think it has also to be mentioned that the target that Malawi would want to vaccinate, it's 11 million. That's 60% of the total population that is currently being targeted for vaccination. And then there is also an issue around the context of a divided opinion, which Mr. Job also indicated. There are a lot of myths, conspiracies, some arising from religion, religious beliefs, and then others also to do with the information that is coming in from the international media in terms of the efficacy of the AstraZeneca vaccine. So those are the issues that will also need to be looked at critically in terms of how do we address those issues. And I think one attempt to address maybe such myths has been the issue around the high profile figures who have got vaccinated during this period. We have had the president, the vice president, the speaker, the chief justice, UN representative, and others who were part of the rollout of the vaccine, and they had to be vaccinated publicly in front of the camera. And I think there is an issue around the civic education, which we have indicated. Unfortunately, I think as Mr. Jobe has indicated, one of the reasons why most NGOs are not into the monitoring of the vaccine and the entire response on COVID-19 is because of lack of funding. There is a high, I mean, most NGOs, most of them have even closed. There are very few that are actually surviving, and that has also contributed in terms of their role in monitoring the vaccine. And the issue around creating the public demand for vaccine, I think this is a critical issue that also goes hand in hand with the debunking the existing conspiracy theories. But then there are some opportunities which we see, I think, as a national human rights institution. For example, the existing public goodwill with the current government following the elections that were held last year, which has strengthened their political legitimacy. That alone can be used actually to also ensure that people are able to hear the message. And perhaps that's the reason why maybe the public, the coming in of the president publicly and vice president to go for vaccination may have some impact. And then there is also the issue around the negative experience of the second wave. Malawi was hit hard under the second wave, where we have even had some senior officials actually who died, and even most people have been really affected with losing their relatives. So that can also be an advantage in terms of moving forward for them, creating demand. And then there is also an aspect around the existing active citizenship in the country around the accountability of COVID-related funds currently. And that can also be an issue that can be also looked at in terms of demanding government's responsibility in terms of ensuring that there is access of the vaccine. Resulting human rights and public health issues, I think one critical issue is around access to information on COVID-19. Section 37 of the Malawi Constitution does guarantee the right of access to all information held by the state in the exercise of their rights, including right to health. And in the current state, as Mr. Yobe indicated, there has been very little information available in terms of the vaccine. So many questions people are asking, okay? Something which is a bit different as compared to how government had earlier on mounted a massive campaign around the awareness of the COVID-19 through the daily updates, which they continuously do. And there is also an aspect around the maximum progressive realization of economic, social, cultural rights. As we know, right to health is one of those economic, social, cultural rights. And while government hasn't come out clear in terms of outlining how they would source the remaining, how they would target the remaining 7.2.
My apologies, Mutale. We might have to wrap up in 30 seconds so that we also give others a chance to share within 3 minutes. So maybe
I just have one slide to finish. Yeah. Thank you. Yeah, and then there is also the issue around human rights do not wait. I think that's an issue around ensuring that everyone is taken on board. And that means government putting in place initiatives that will ensure that access is actually enhanced. And then there is an issue around accountability, which have actually put in place. Lastly, the equitable access to vaccine. I think we have lacked the targeted approach, which is currently being implemented, where there are selected groups that have been prioritized for the first phase. But I think there is need for more coordinated effort. I think, as Mr. Yobe indicated, the civil society seems to be left. Even the National Human Rights Institution, we are not part of the monitoring. So I think there's need to do more on that. Thank you so much.
All right, thank you. We can have the next speaker, who is Tanvir from Mauritius, if I'm not mistaken. Yeah.
Hi, everyone. If I could please, okay, great. Can everyone hear me?
Yes.
Okay, lovely. So as introduced, I am Tanvir Jiwa from Mauritius. And in all transparency, right now I am based in South Africa. And just to give a quick overview of the situation in Mauritius, Mauritius is one of the African countries that have fared fairly well compared to other African countries in relation to the COVID-19 pandemic. And the reason for that, I do believe, is that we have a smaller population and the borders were easily controlled. But as many of you might already know, although Mauritius had been a COVID-free country, I think for the past, from June 2020, there has now been COVID cases discovered again in Mauritius and the borders have closed down. So in the recent past, Mauritius has received AstraZeneca vaccine doses from India through what I believe are bilateral agreements. And there were 100,000 shots that were received. And although Mauritius has not technically publicized a full vaccine rollout plan, there are things that we already know. For example, the fact that vaccines were given to nurses and frontline health workers, such as doctors, and also workers in the tourism industry, because as many of you already know, Mauritius is very reliant on its tourist economy. But what we have just found out today, in fact, in a breaking news moment, is that the judiciary was supposed to be vaccinated today as being part of the frontline workers as well. And they have refused to be vaccinated because there was a lot of rumors and a lot of news around AstraZeneca vaccines not doing what it's supposed to, based on a lot of reports from European countries. So the judiciary has refused to be vaccinated today. And we see that Mauritius, being a more privileged African country, faces different kind of problems. So because we have been able to secure a lot of vaccine doses, we were projecting to be able to reach herd immunity because our population is 1.3 million, which is not a lot of people. We were presumed to reach herd immunity in 2021 itself. But right now we're seeing a lot of vaccine hesitancy, for example, with the judiciary refusing to get vaccinated, and which really should raise an alarm because the judiciary, as everyone knows, is placed quite highly in almost every country, and the major population does look up to the judiciary. And if the judiciary, for example, refuses to be vaccinated, which is obviously legal and allowed, that will cause more vaccine hesitancy in the broader country. And while there isn't a lot of data available as to the vaccine hesitancy broadly in Mauritius, there are some anecdotes which I have found for myself and heard friends speak about. For example, that I know that there's a lot of rumors going on that the vaccine itself might cause more harm, allegedly, than COVID-19. So we need to rethink the information campaign that's going on in Mauritius. Right now, there's not a lot of information on vaccines. As I just said earlier, we just found out today that the judiciary was even supposed to be vaccinated, let alone the fact that they refused to be vaccinated. So there's not a lot of information as to vaccine, but this is not a criticism of the government per se, because recently we have found more media coverage on who's getting vaccinated and who isn't. But for example, we still don't know whether prisoners will be among the first people to be vaccinated in this rollout plan. But what we do know are some really good things, such as, for example, the vaccine will be available for free, Mauritius being a welfare system, but not only to Mauritian citizens. Right now, Mauritius has developed a kind of premium visa, which will allow non-Mauritians to get vaccinated for free as well. I have also heard, and again, some of these things are official and some of these things are things that we're hearing because there's not that much transparency as to the rollout, but we have also heard that the elderly will get vaccinated from home and people will go there, the health workers will go there to give them the vaccine. So just to point out that the situation and the issues that happen in Mauritius in relation to the COVID-19 vaccine are very different from issues that other African countries might face. But on the plus side, and if I were to stop here, which I think I have already reached my 2 to 3 minute update, would be to say that Mauritius has vehemently supported the TRIPS waiver, which is really good to know, because despite having been able to secure its own vaccines bilaterally, it has still not blocked the waiver or even stayed quiet, but rather it has actively supported the TRIPS waiver. So really right now, what we ask from the government is more transparency, more information as to the vaccine itself, as to the rollout, and also eliminate vaccine hesitancy through this transparency and through this information. Thank you very much, Arnold, and thank you to all of our speakers who have joined us before and will continue speaking.
Right, thanks a lot, Tanvir. Now we move to Dr. Jorge Martine from Mozambique. Do we have Dr. Jorge Martine from Mozambique?
Boa tarde.
Right.
Sim. Boa tarde, conseguem me ouvir?
Yeah, you can go ahead. Thank you.
Muito obrigado. Penso que a experiência de Moçambique não difere muito da experiência dos outros países que aqui apresentados. No caso de Moçambique, o plano de vacinação foi lançado em março, né, 8 de março, e até agora Moçambique já vacinou 46 mil pessoas, nesse caso profissionais da área da saúde, do universo de 61 mil. Esta é a primeira fase, que abrange os trabalhadores de saúde, os serviços de defesa e segurança, não é? E a segunda fase, que vai iniciar depois da segunda dose, que vai ser administrada para esta primeira fase. A segunda dose está prevista para 29 de março. Então, a segunda fase vai ser está previsto que vai abranger pacientes com mobilidade, vai também a população prisional e pessoas com necessidades especiais e acima de 50 anos. Depois disso, vai à terceira fase, que vai para... ainda não está muito claro qual será o critério de inclusão, mas espera-se que será uma fase que poderá expandir para os 17% que se espera que é a meta prevista. Moçambique espera vacinar 20% da sua população. Neste momento, essas fases que falei correspondem a 3%, não é? E Moçambique espera que com a vacina da COVAX e a vacina vindo do sistema da COVAX e a vacina que recebeu da China possa cobrir os 20% da população. Em termos de plano de vacinação, Moçambique já tem um plano de resposta à Covid. Este plano é bastante exaustivo, mas até agora este plano tem um déficit de 101 milhões de dólares, tirando tirando as vacinas que não estão inclusas. Então, o déficit de resposta ao plano continua ainda muito alto. O governo espera, com as vacinas, gastar cerca de 21 milhões de euros. Não é? O plano de vacinação espera gastar 21 milhões de euros. Isto colocado ao déficit que nós temos do plano de resposta à vacina, falamos aqui de mais ou menos 125 milhões de dólares, que seria as necessidades. Mas poderemos também aqui levantar alguns desafios em relação à equidade que já tinham sido levantados já no plano da testagem, não é? Quando o plano de testagem, que também demonstrou que a questão da equidade era bastante importante. Vimos um grande movimento do setor privado a fazer uma testagem massiva e que foi excluindo um grande número da população. A testagem feita pelo Serviço Nacional de Saúde não foi expansiva como esperava, por vários desafios que o sistema público tinha, ou tem, relacionados com os recursos para poder financiar a testagem, a resposta tardia também dos doadores em garantir que os recursos estivessem disponíveis no país, mesmo aqueles doadores que diziam que iam dar in kind, a chegada dos produtos ou dos materiais foi muito tardia. Então, na primeira fase, na fase de testagem, vimos uma grande falta de regulação, vimos uma primazia para o serviço privado em detrimento do serviço público, e este é, neste momento, o grande desafio em relação ao processo da vacinação. É se o processo de vacinação, o plano de vacinação, vai colmatar os desafios que estivemos com o plano de testagem e o plano de distribuição de materiais do EPI, não é? Nós vimos que aumentou o fosso de desigualdades e também vimos que o nível de preparação para maior inclusão, quer em termos de critérios em relação à testagem, quer em termos de critérios em relação à ao internamentos foi bastante questionado. E disto foi visto, por exemplo, o posicionamento dos médicos, da Associação Médica, ou da Ordem dos Médicos, e da posição da Ordem dos Enfermeiros, em relação àquilo que é os desafios do plano de resposta à Covid e do plano de vacinação. Agora, é preciso aqui também chamar a atenção que a nossa advocacia como sociedade civil, nós advogamos que era preciso incluir na primeira fase os ativistas comunitários, os community health workers, porque depois do plano do decreto do estado de emergência, estes ativistas não foram incluídos como pessoal essencial para continuar a manter um serviço de saúde funcional, público, e pelo papel que desempenham na assistência a doentes crônicos ou doentes com necessidades especiais. Então, nesta questão de vacinação, a sociedade civil se propõe na discussão com o governo para a inclusão, e conseguimos até agora que o governo pudesse pedir um plano à sociedade civil do número de pessoal ligado a ativistas de saúde que poderiam ser beneficiados dessa segunda fase, na segunda fase da vacinação. Em termos conclusivos, podemos dizer que os desafios que nós assistimos em relação à testagem, em relação à proteção do pessoal sanitário, poderão ser exacerbados também num processo de vacinação. Por quê? Primeiro, porque os processos de inclusão continuam, apesar de parecerem claros, continuam ainda bastante frágeis, não é? De gestão, e também porque um processo de vacinação que vai levar 24 meses, pela experiência que nós temos, é de que ele recebe maior atenção de recursos públicos numa primeira fase, nos primeiros 3 meses. Depois disso, ele vai simplesmente perder a liderança política ou a força política de poder mobilizar todos os recursos para a questão da vacinação. E aqui penso que é preciso que, como sociedade civil, continuemos a monitorar o plano de vacinação, chamando a atenção de que este plano de vacinação não significa que devemos deixar de prestar atenção ainda a 2 pilares importantes, que é o pilar da testagem, que ainda continua a ser um grande problema no país, e o pilar do tratamento, que também continuam a ter, os hospitais continuam ainda a ser uma grande preparação para receber a pressão de doentes que necessitam de apoio sanitário. Este seria a minha comentário em relação a Moçambique. Muito obrigado.
Thanks. Sorry, just before Arnold comes in, sorry, I want to apologize to people that we are going over time here. I know Arnold might do it too, but it was my session that cut into Arnold's time, so I'm apologizing for that now. And we really do want to give a platform to all countries to be able to speak before we move forward. So apologies that we're running over time a little bit, and thanks for your indulgence. Sorry, Arnold.
Yep, thanks, Tim. So we move to the next speaker, who is Felicita from Namibia.
Thank you, Arnold, and good day, everyone. I will try to rush through this quickly. I mean, the most information we've received about the Namibian government's plan around COVID vaccines acquisition and allocation, we actually received yesterday with the arrival of the first 100,000 dose of vaccines donation from China. And so suddenly we have a little bit more information on what the plan is. Apparently the government aims to vaccinate 60 to 80% of the population. They have a 2-track COVID procurement plan, which includes pooled procurement. And they have been negotiating with COVAX for about 20% of the need. And the vaccines from COVAX were due in January, but have not yet materialized. The second track of the procurement plan includes open international bidding. And as part of that process, they have actually recently issued a call for applications or call for bidders to provide COVID vaccines. And I'll speak a little bit more to that when I get to the kind of concerns around procurement regulations and the flouting of procurement provisions that were in existence before COVID-19. Apparently there is a COVID vaccines task force that is tasked with reviewing the latest evidence, training needs of the healthcare workers and all regulatory and legal and safety frameworks. But we have not been able to find information on who is on this task force. There's apparently also a COVID vaccines plan or a deployment plan, which is what we heard about yesterday with the arrival of the first doses. We can't find any information around very many specifics of the plan, but also whether the NGOs, other parties have been engaged in the development of the plan. But according to the ministry, the Namibia Medical Regulatory Council is providing the necessary guidance and regulatory oversight. And obviously that does not include civil society or most at-risk people, etc. The first 100,000 doses that arrived were the Sinopharm vaccines, and they will only cover about 4% of the population. But in addition to the Sinopharm vaccines, the government has made a financial commitment to pay around $9 million to COVAX to supply the Johnson & Johnson, AstraZeneca, and other vaccines. But obviously, as I mentioned, there have been delays with receiving those vaccines. Apparently, MTN, which is a telecommunications group, will also donate 7 million doses through the African Union process, but that also no date for arrival has been confirmed, and there are not many details as to what types of vaccines will be procured through that system. But in addition to all of that, the government has also engaged vaccine manufacturers in the US, in India, and Russia. But those negotiations apparently are also going very, very slowly. In terms of the plan with the vaccine rollout for these 100,000 doses that have arrived, the government will make use of the existing infrastructure and human resources of the existing expanded program on immunization. The vaccinations will start in phases from the 19th of March to the 16th of April. And obviously the Sinopharm vaccine is a 2-dose vaccine. They will start at health facilities in 2 of the regions of the country, which is Khomas, where the capital city is based, and Irongo at the coast, which have been hotspots in the country. They will target frontline workers, community healthcare workers, persons between the ages of 18 and 59, which is quite broad, persons in closed settings, such as prisons, and those in cross-border transportation, including truck drivers, and pilots, immigration officials at ports of entry, police officers, journalists, members of the diplomatic corps, mining and fisheries employees, religious and traditional leaders, people with disabilities, minorities, and other and refugees, which is quite a broad kind of target. But they mentioned specifically that those above 60, pregnant women and lactating mothers will be excluded at this stage while they get more information on the efficacy and side effects of the Sinopharm vaccine as it pertains to these specific groups. The rollout plan for the rest of the population has not yet been communicated, but the Ministry of Health has assured the country that the vaccines will be provided free of charge to all citizens. We've also received reports that private medical aid funds committed in February to pay for the costs related to the COVID-19 vaccines on behalf of their members, which will cover about 8% of the population, which is about 200,000 citizens. Some of the concerns that I wanted to raise regarding the vaccines rollout and acquisition in Namibia pertains to some of the procurement related challenges. And in particular, just wanted to mention that on the 10th of March, the government advertised calling for prospective bidders who would be manufacturers, agents, distributors, and suppliers to supply COVID-19 vaccines that would supplement what COVAX would provide, as well as the donations that have been pledged. But there have been criticism that they are trying to introduce an intermediary structure that will inflate the cost of the of the vaccines, because obviously if you're getting an agent, the agent will take their cut, and then you have to still pay the manufacturers. It's in all the other kind of logistics related costs as well. But the government has said that they will actually prioritize the most responsive bidders, which means that they will look for the most competitive bidders according to price, delivery period, lead time, and product compliance. And if no competitive bidders are found, they will then go back to, looking at the pool procurement through COVAX, as well as direct procurement from the manufacturers, which they should do, prioritize in the first place anyway. But other concerns are also around community readiness. I think that's been mentioned several times by other people as well, and as well as the country's capacity to store the vaccines in optimum conditions. And then I wanted to just highlight, that I think up to now I haven't heard much talk about the role of SADC and the SADC Secretariat in kind of harmonization of approaches and some of the regulations that are put in place regarding COVID-19 and the vaccines rollout. And with that, I thank you.
Right, thanks a lot, Felicita. So can we move to Joel Barnes from Seychelles?
Hi, yes. Just waiting for my computer to wake up. Can you hear me, Arnold?
Yeah, yes, yes, we can hear you. Thanks.
Okay. Hi, everyone. I am actually a South African, but I'm living in Seychelles, where I'm an assistant lecturer at the university, and I've also been working in the Office of the Chief Justice for the last 6 years. Seychelles has a particularly privileged position when it comes to this vaccination discussion, because we have a population of 100,000 people. So it's had the benefit of really being able to address the situation quite quickly and quite effectively. So perhaps our discussion really is from the experiences of a country that has managed to do quite a lot of vaccinating already. So we achieved enough vaccinations to cover the entire population through bilateral aid agreements, and we have already received 50,000 doses, which is 50%, and the rest are coming in as we go. So Seychelles has had difficulty with the change of government, which means that we've had a change of policy in the middle of trying to deal with the COVID situation, as well as an income that's been devastated by a year without tourism, which is our primary income for the country. As a result, the focus for the government was getting the workforce back to work, and so while there's been no published plan for the vaccination rollout at any point and no engagement with society, we started vaccinating the second we got vaccines into the country. And this has, as we got Sinopharm from the government of China first, we rolled it out immediately, and primarily to our under 60s population. So not the most at risk and not our frontline workers, although it was available to anyone who was under 60. So, and the target rate for the government is that 70% of the population, so 70,000 people, will be vaccinated. So far, they have managed to roll out 62,000 first doses of the vaccine, which means that 89% of the target population has received their first dose, which is phenomenal. However, the uptake of the second dose has been exceptionally poor, and we've only seen 39% of the population be willing to come forward for the second dose, which is worrying because it shows that there's some form of difficulty regarding people refusing to take the vaccine, but also refusing to take the second dose of the vaccine, which was an unexpected difficulty that they're running into. So from a rollout and a preparedness point, it might be interesting to just discuss what Seychelles has done. We had a similar thing where senior politicians and leaders in government took the vaccine first, all of those who were under 60 who were able to and eligible to. We have since started rolling out the AstraZeneca vaccine to people who are over 60. They set up vaccine sites across the country. They were in community centers, and they used nurses who were not working directly in the hospital. They used nurse students and retired nurses in order to make sure that they were able to roll it out at the same time as dealing with a massive number of cases. As far as Seychelles is concerned, we've had 3,000 cases in the last 2 months, which is after a year of only having 250 cases in the whole year. So you can see we were suddenly quite inundated with COVID positive cases after the South African variant and the British variant became prevalent in Seychelles. So they've been quite effective with rolling out the vaccine. One of the areas it's been quite slow in, they've done personal education and personal counseling prior to receiving the vaccine, which has slowed down the process. And there's definitely ways that they could use public awareness and technology to make the process more efficient and more effective. As I said, the government has not been transparent about its policy. They haven't told us where the 70,000 target came from or who's meant to be covered by it. They also were not particularly good with explaining when the different people would have access to the vaccine. So at first there was lots of concern and confusion, but it appears to have really subsided in the last few weeks. The next step that's going to be difficult is with getting over the barrier of people who are refusing the vaccine. I think there is, similar to Zimbabwe and some of our other colleagues have mentioned, a distrust of the government and a distrust of the vaccine. People say they don't want to be used as guinea pigs, which is difficult. There are Facebook pages which have spread quite a lot of fear and misinformation. Again, not something that's dissimilar to the rest of the continent. The AstraZeneca also has significant side effects when you take it, and I think that might be one of the reasons why people are not going back for the second dose, is because of the significant illness that they face when they take the first dose of the vaccine. Not everyone, but a large number of people. There are now, as the country is starting to open up, we're facing new human rights implications, such as whether there will be discrimination based on the vaccine. These are matters that have not been discussed in the country and have not been addressed, such as whether there'll be restrictions on travel, restrictions on work for people who've refused the vaccine or who have taken it. And of course, concerns about whether vulnerable persons who are excluded from being able to take the vaccine for medical or other reasons will then be discriminated against. And that hasn't been addressed. There's also a lack of transparency about the vaccine itself. There's very little information on the Sinopharm vaccine and the policy for rollout. So Seychelles' situation is very different because of its size and its ability to reach the entire population. But we would like to see an increased discussion about the human rights implications once our vaccine has already been out. Thank you so much.
Right, thanks, Joe. So now we move to our last speaker, who is Sibongile Chabalala from South Africa.
Good afternoon, everyone. I hope I'm audible.
We've got you, we can hear, and we can see you too.
Yeah, like other countries, South Africa has already started, I think all of us we know, the implementation of vaccination, especially to healthcare workers. We started early this year. However, there are a lot of politics, as Fatima indicated earlier. There's a lot that is happening and the government is trying to do. The inclusion of civil society, yeah, this time around, we can safely say yes, although they cannot include everyone, but most of the civil society organization or civil society is consulted and a part of the vaccination plan. However, there are still challenges when it comes to education on the ground. Remember, South Africa, it's as much as is in the middle income country, but we still have those deep rural areas where information is hard to reach, where those communities are the last one to access any services in South Africa. So even this time around, we haven't still heard any plan from the government to say how are they going to reach those hardly reached places or areas like your rural areas, the deep rural areas, which we have about 3 provinces in the country that have that kind of places. We as civil society on the ground, we are doing a lot when it comes to COVID-19 information, COVID-19 hesitancy and other things. However, we still have a responsibility to build more confidence, especially to people on the ground. We have a challenge of social media that is being used not adequately, and where myths and information that is not true, it's mostly publicized, and in almost every day we respond to wrong information that people are providing on the ground. And also we have doctors and professors here in South Africa who are anti-vaccines or who are anti the plan of vaccination, which it makes it so difficult. In a few days, I received a video call from one of the doctors who was giving half information to people about vaccine, and who was encouraging people not to access J&J vaccine, as we all know. And I think everybody spoke about AstraZeneca, that South Africa has stopped using it because of its efficacy. However, the issue of COVID-19 and vaccination and everything that is happening, the pandemic has also affected us mostly, especially on the ground, will be the ones that are hard hit. Recently, in a week's time, last week, there was a budget allocation, and our Minister of Finance cut billions of rent from health, and those billions of rent were taken to fight to COVID, which is a good thing. However, South Africa has a lot of illnesses that we are dealing with. We had cancer challenges that we haven't managed to find ways of dealing with. We have a health crisis that is in shambles, of which we've been talking about it to say our health crisis is in crisis, and now it's worse because of the issues of COVID. And as I'm talking to you, in KZN alone, 1.3 billion, it's been cut from their budget, which means most of the work on the ground will be affected, and mostly people who will be affected by this are people on the ground. Also, prophylaxis literacy, it's very important on the ground, because as much as we know that there have been vaccines that have been vaccinating people from the earlier age or from long time ago, we know that we've been having BCGs, we have polio vaccines, we have other types of vaccines. However, people, they still don't understand the vaccines, the trials, and everything that has to do with vaccines. So because of time, I won't say much. However, what I can say is that what we need to focus on mostly in South Africa is taking the information and not send the scientific information. Our government, they are trying, but only through social media, only through technologies that are there. However, we have so many communities that are not using these technical social media and technical platforms. Even if they televise on television, most of the time it's so scientific for people on the ground to understand. But then, yeah, as civil society, we are there to make sure that everyone access information and it's simplified so that everyone can be able to understand. Thank you.
Okay. Thank you very much, Sibongile, and thank you to everyone who's presented during this great learning and sharing session that we had. And apologies for overstretching the time, but it was also good to listen to more than 75% of the countries within the region. So this has been quite interesting regional learning and sharing platform that we've had. So now I hand over to Mandipa, my colleague, to facilitate the closing sessions.
Thank you, Arnold, for moderating that power session. Thank you, everybody, our participants. We actually had full participation from all SADC countries, save Tanzania. But I think we all understand why people from Tanzania would be a bit reluctant to speak on public platforms. But in saying that, I would still like to thank some of our participants who also put themselves and their personal safety at risk by speaking to us, countries where there's been quite a lot of state suppression in relation to vaccine access. We haven't been able to get a lot of information, so their sessions were really, really invaluable for us and our research and also our planning going forward in relation to advocacy. I'd like to apologize again for the third time, I think, about time. We really had wanted to have an inclusive conversation, and I think everybody kind of gained something out of it, different countries' perspectives, some similarities, some differences, and I think we'll be able to work better together forward, knowing the context of all the various countries within our region. In saying that, I would now like to hand over to my regional director from Amnesty International, Deprus Muchena, who is going to close this session for us. Thank you, DM. Can you take it away?
Okay, thank you, Mandipa. And thank you, colleagues, everyone who is listening, who participated today. This is an important convention. This is an important gathering. I mean, the fact that we're able to get as many of the countries in Southern Africa indicates a particular commitment that we all share about the importance of regional integration, regional action, in order for us to claim a place on the international stage with respect to the question of vaccine access. So we really want to thank colleagues who have stayed right through the end and those who have left.
Can anyone else hear, or is it just me who's not hearing?
I can hear him, but I think Tanvir is saying she
Okay,
can't
sorry,
hear him.
continue. Let's see if it's, sorry, Deborah.
Sorry, Dave, yeah.
Okay, all right, thanks. So I was essentially just thanking people who have come, because we really want to mount an effective regional and global campaign on the themes that have emerged during this conversation, but themes that we are currently working on as different actors, human rights defenders, the three conveners of this meeting, so that we claim a space and a place in the global conversation on access to vaccines. So upfront, I think you should expect us to send an invitation for a second meeting, variation of a meeting, focused now on developing a plan or working together to develop an advocacy plan that gives us a roadmap towards what sort of moments do we want to affect now going forward, given the fact that what's happening in each of the countries, including when the next SADC Council of Ministers of Health meeting is taking place, when the next SADC summit is taking place, anything that we can materially influence, so that we put front and center questions of human rights, protection, state responsibility, and do no harm principles at the center of the rollout platforms that we're starting to see. I think it's important to state that we are dealing with a global pandemic. It did not originate in Africa. It originated in Wuhan, a city that is very wealthy, 10 million people, 16,000 USD GDP per capita. But it has spread to the global south and to very poorer countries in Chitipa, in Malawi, in Buhera and Zimbabwe, and in many other poorer communities. So because of that, it is important for us in Africa to really demand international action and state cooperation at a global level, because none of the people who are now dying from COVID-19 started it or were responsible for it. Like previously, before, we have dealt with slavery, a phenomenon that we did not create. We have dealt with colonialism, a phenomenon that we did not create. We have dealt with economic crisis, climate change, and other economic, political, and environmental disasters that are taking place across the world. The disproportionate impact on Africa continues to be a major story of the toll that our humanity is taking. So it is important that I think we deserve to be heard as an African people. We also deserve to take a seat on the table in discussing where we are going globally. For that to happen at a national level, I think we need to have systems that are durable, strong enough, inclusive enough to make sure that various barriers that divide us are overcome by distribution of the vaccine to people who need it. It is unfortunate that we still have to deal with governance problems on our region. We still have to deal with problems of authoritarian resurgence. So if a country before COVID-19 hit itself had problems of governance and authoritarianism, COVID-19 simply amplified those problems. So when information was not being shared before COVID-19, it's not being shared now. And that is important for us to link up with those human rights campaigners who are working in the broader area of human rights and governance so that we improve access, flow, reception, and distribution of information in order for all of us to put a claim on the sort of accountability we need from states and from our governments. I also want to raise the point that, for a campaign of this nature to be effective, it is to be rooted on the analysis we received from Professor Shebia, who spoke in the morning, and Fatima Hassan, who indicated to us that we generally face a problem of diagnostics, we face a problem of vaccines and of therapeutics. When, in fact, the COVID-19 pandemic hit South Sudan, the country had 5 vice presidents, and 4 ventilators. That is the level of investment into therapeutics in the country. If you look across Southern Africa, it was also the same. So it's very, very important to root our campaign on an effective analysis that is more systemic, as we received from our speakers. We have received very rich material to now work with from inside the various countries, such that we can mount a campaign going forward that really forces our states to prioritize human rights and put them at the center of everything that they do so that we protect our citizens. I think there's been a fierce debate, and it has been reproduced in different inputs around the waiver that WTO ought to do on the TRIPS agreement in order to facilitate access and treatment on COVID-19 with respect to the limitations that are there. As a region on the continent, we really must fight to reduce, to tear down the walls and barriers that have been erected to prevent ordinary people from accessing the vaccine. So with this respect, we applaud the efforts that were started very early on by Oxfam on the people's vaccine as a common pool resource, a global commodity that should be decommodified and made accessible to all people across the world. I think that effort needs to be strengthened by working with us, by working with the International Commission of Jurists, who have been working very significantly for a long time now on right to health campaign and ensuring that the judiciary plays a key role in becoming a facilitator and accessing justice. Amnesty's global campaign on the Fair Shot that we just launched recently will become a key part of the platform that we can mobilize for voices we had today to be understood. It was heartening to listen to the many stories that are coming from far and wide in the countries that we have listened to today. And we saw a combination of public health workers, doctors, nurses, civil society groups speaking from each of these countries. We want to retain this, this assemblage that we've put together so that we speak more forcefully and more strongly going forward. Last on the issues is to tackle big pharma. We know that there's been an attempt to privatize profits and gain and socialize losses and pain to the rest of us. I think we cannot continue to accept a situation where public funds are utilized to support research and development of vaccines, but profits are then privatized in the name of all kinds of justifications. We know that we are facing a global crisis of leadership after the last 4 years of a Trumpian regime in the US and retreat of the European Union from global issues in an effective way. But we have to remobilize international leadership. And where we can't find international leadership, we have to work with those states that are trying to provide leadership to deal with this pandemic. Very happy to hear what we hear from Seychelles, from Mauritius, where the government there is supporting the waiver. Countries like Costa Rica have been talking about the setting up of a COVID-related technology pool so that you lower access to technology and maximize access for different countries to ensure the wider populations are reached. I think we have to work together to really put an onslaught on global capital represented by big pharma for the kind of barriers that they are putting in place. With that, I think the next meeting that we're going to call for around advocacy and proper planning, working with all of you that came today, will hopefully give us something strong to contribute to the global movement on access to vaccines. And with that, I really want to thank the colleagues that worked on this, Mandipa, Sasha, CD from Amnesty, very well team, Tanvir, Alicia from ICJ, and Arnold, Joab, and others from Oxfam, supported by their directors. I think we must continue to work together, and all of you who have stayed right through the end. So thank you. Back to you, Mandipa.
Thank you so much, Debrose, for that. I think it was, quite an all-encompassing closing speech. We definitely have a lot of work to do, but I think we have our work cut out for us now. Previously we were walking in the dark a little bit in relation to information because this is quite a fast-moving area. So many countries in the recent days, literally days, have started to vaccinate and get their vaccines. So I think this is quite a fast-moving train, but we're very privileged to have been able to get this a very sub-regional kind of view of what kind of problems we can be able to tackle going forward. As my regional director said, we will definitely be contacting you with a way forward in relation to drafting a regional advocacy plan, which is going to take into account all of the issues. We had really wanted to have a short question and answer session, but I don't think we have time for that. But I see that there's some activity in the chat room. So I think for anybody who wants to kind of have a discussion there, go ahead. Although we probably will be closing the meeting in a few minutes. Thank you so much for all who powered through till the end. Thank you for all of the amazing contributions that we have. And we will definitely be getting back to you soon with a way forward. Goodbye.
Thanks, everyone. I think we can stop recording and streaming now. And thanks for everyone who stayed for so long, as everyone has said.